Family medicine is the key to matching at your dream residency, and most students struggle to master it. I remember feeling completely overwhelmed before my shelf. Then I realized the secret. Family medicine actually tests the same core principles that appear pretty much everywhere in Step 2. Today, I'm revealing exclusive footage from our paid course, real coaching sessions showing exactly how students crushed their shelf in Step 2. These patterns don't just boost family medicine, they automatically improve your odds in every Step 2 question. Watch how understanding these transforms the broadest shelf from chaos into predictable points. One of the most powerful ways of learning anything in medicine is to think of it as a framework. So one framework that you guys are probably familiar with is the framework of an AKI, acute kidney injury, where you've got an increase in creatinine because you have a decrease in the amount of filtration that's happening in your kidneys. It can happen because of one of three general mechanisms. The first is a pre-renal AKI, which is where there's not enough blood, right, which is being filtered by the kidneys. There's not enough blood that reaches the kidneys, which means that there's not going to be enough blood to be filtered, right? So that's one reason why you would have a decrease in filtration and therefore an acute kidney injury. The second is that there's a problem inside the kidney itself with the filtration mechanism itself. So an example of this would be an intrarenal AKI, something like ischemic ATN or acute tubular necrosis, right, where there is a decrease in the ability of the kidney to actually filter itself. And then finally, you've got a post-renal AKI, which is where even though there's blood that's reaching the kidneys, even though there is no problem with the filtration mechanism, because there's a blockage downstream of that, so maybe there's like a stone or something like that, that you can still have a decrease in the amount of filtration. All right, so most of you are probably familiar with this as a framework. What you're going to learn next is another framework that is analogous to this that can help you to understand the causes of hyperbilirubinemia generally, and that will allow you to understand LFTs. For hyperbilirubinemia, you can use pretty much the exact same framework. You've got prehepatic, intrahepatic, and posthepatic causes of hyperbilirubinemia. So in the case of prehepatic, you'll have an increase in hemolysis. So it would be an increase in the amount of bilirubin that's being produced because there is a greater breakdown in the amount of heme, which is ultimately going to lead to an increase in bilirubin production. Second, you can have an intrahepatic cause of hyperbilirubinemia, right? So this would be akin to having ATN in the kidneys, right? This is like hepatitis or things like that, where you would have a decrease in the ability to conjugate bilirubin, and therefore you're going to have more bilirubin that is both conjugated and unconjugated that is going to then spill into the blood. And then finally, you can have a posthepatic cause of hyperbilirubinemia, which ultimately is going to cause you to increase the amount of conjugated bilirubin, because now there's a decrease in the ability to clear out the bilirubin through the biliary tract, like in, say, choledocholithiasis or some kind of other gallstone. All right, so this is just a preview of what it is that you're going to learn in these next lessons. In addition to that, be sure to stick around because there's also going to be a framework for understanding pretty much every single endocrine disorder, as well as a cardiology framework to understand any of the shock or vitals questions. So again, without further ado, please enjoy these lessons.
The question is asking, what is the tubular osmolarity compared to the serum in each of these three places in nephrogenic diabetes insipidus? And so we all agree that the medullary collecting duct would be hypotonic compared to the serum because you don't have the ADH to reabsorb your water, which would normally be occurring in the medullary duct. Stop me if I'm wrong or...
Exactly.
Okay, and then at the juxtaglomerular apparatus, we're also saying that it would be hypotonic because a normal person would respond in the hypotonic situation by releasing ADH or in your RAS, but she can't do that, but it would still be hypotonic. And then I was a little hung up on the proximal tubule because I know that it has isotonic reabsorption, and so I was wondering if compared to the serum, even though our serum is lower, not as concentrated as ours would be, it would be isotonic.
So who would like to answer that question? So what is the osmolarity in the proximal tubule? Who can answer that? If you don't say anything, I'm going to pick on you guys. Let's go with Mo. Mo, what do you think?
It's isoosmotic.
Iso. Okay, and why is that? Why is it isoosmotic?
Because of bulk flow, which was like everything goes through the basement membrane. That's like where the
because everything goes through the basement membrane. That's true. But what about all the reabsorption? Like Melissa was saying, but what about all the reabsorption of that solute? Well, I'm gonna pick on Maria. Maria, what do you think?
I know the fluid is supposed to be isotonic.
It's supposed to be isotonic. Yeah. Why?
Yes, because you are in glomerulus, you're putting a lot of water and solutes inside of the tubule. However, over 75% of it will be being absorbed.
Yeah.
And it's probably isotonic, but
Probably isotonic, but we're not sure. Okay, so this is important, right? You got to be sure about this stuff because they're gonna push you. They're gonna give you lots of different choices, and if you're not sure, it's gonna be really tough. So let's make this really simple. So this will always be isotonic. The reason is that you are absorbing water and solute at the same time. So water can follow the solute in this case, okay? Which means that if I take out solute, I'm going to have an equal amount of water loss, which means this is always going to be isotonic. So these questions that you guys get, they're going to try and trick you, but this is always going to be isotonic, no matter what. No matter if you give them diuretics, it doesn't matter. It's always going to be isotonic. Okay. Now let's talk about the descending portion. So what allows it to get more hypertonic as we go down? We talked about this last time. So I'm going to ask Lindsay, why does this become more hypertonic as we descend?
Down the thick descending limb.
Yeah.
Okay, because you are only permeable to water, and so your water is being reabsorbed, but your solids are staying in the lumen.
Perfect. Okay. And so Chris with a K, why would it become more hypertonic as we go down? But yes, it's only permeable to water, but so what? Like, why would water choose to leave? Because that's essentially what we're saying, right?
When we think about countercurrent multiplication, if we look at what the thick ascending limb does, it kicks out all the solute into the medulla.
Kind of. Let's put our nickel down. I want you to be precise.
Okay, so you can think about it as moving all the solutes into the medulla from the limb. So the purpose of that is that the entire medulla can become more salty, as it were, and then water from the descending limb will follow.
Yeah, that's great. That's fantastic. Does that make sense? I actually really like that explanation. So the thick ascending limb is basically salting the medulla. Never really thought about it that way, but that's true. We're salting the medulla, so water leaves from the descending limb. So as you get lower, it becomes more and more hypertonic, right? Now, so we posed this question last time. Are thiazides or loop diuretics more likely to predispose to hyponatremia, and why? Who can answer this question for me?
I think it's thiazides because it doesn't interfere with the countercurrent multiplication.
Okay, perfect. Can you explain? So thiazides because it doesn't. Okay, so what?
Actually, I never fully understood that. I just remember it from like studying the PowerPoint, but I never understood it. So I wanted to hear it from this discussion.
Sure. Can someone explain it? I bet Chrissy. Yeah, I knew it. Let's hear it.
Okay, so thiazides work in the distal convoluted tubule.
Yep.
So their mechanism isn't involved with establishing the medullary gradient, but loop diuretics are. And so when you loop diuretics, you would change the degree with which you absorb salt and water to the same degree, so you don't risk uncoupling that and getting less of a salt concentration.
Wait, uncoupling what? The last part.
The salt and water reabsorption.
Okay.
In the way that water always follows salt. You keep that ratio stable with.
Ratio stable. Okay.
Whereas with loop diuretics, you would block the NAKCl transporters, and so you would mess up that ability to concentrate urine.
Yeah, that's pretty good. So does that make sense? So the reason why I like these sorts of questions, okay, so if you can understand the answer to this question, it means that you definitely understand countercurrent multiplication. Like you have to understand countercurrent multiplication to explain the answer to which of the two, thiazides or furosemide, are going to give you hyponatremia. Okay, so
Can I hear the explanation again, please? Sorry.
Yeah. So let me explain. So in a very big picture sense, the entire basis of countercurrent multiplication is the fact that in the ascending limb, only salt moves and water can't, right? It's permeable to solute, but not water. And in the descending limb, it's only permeable to water and not solute, right? So those facts, coupled with the fact that you have a sodium-potassium 2-chloride channel, that sets up all of countercurrent multiplication. If one of those things were not to be true, you couldn't have it. So in this case, you're blocking the sodium-potassium. So in the case of furosemide, if you block the sodium-potassium 2-chloride channel, they could easily ask you this question. They could ask you, what would be the osmolarity in the proximal tubule, in the distal convoluted tubule, and in the distal collecting duct? They could ask you that question. That would be a fair question. So Who wants to give a stab at that? Because that's tough. This is like we're talking like 230, 240 level question on step 1. If you could answer this, like most people wouldn't be able to answer that because they wouldn't have the depth of knowledge to be able to answer that. So who wants to give that a shot?
Can you repeat the question?
So the question is, in the case of giving someone furosemide, what would be the osmolarity in the proximal tubule, in the juxtaglomerular apparatus, and in the collecting duct?
So the proximal tubule is always isosmotic.
Always isotonic. Good. So you can eliminate 2/3 of the answers just based on that. Okay.
And wait, osmolarity in the tubules or in the blood?
So let's say the distal convoluted tubule and in the
Oh, the
collecting
tubules.
duct.
Okay.
The collecting duct canthakia would be hypertonic
Hypertonic? Okay, why?
because the point of furosemide is to remove water. If you lose water, you remove solutes. And if you're blocking the sodium potassium chloride channel, there will be less ions coming to the medulla. So they're going to stay inside of the tubule. So for me, it makes sense that it's hypertonic because a lot of solutes are staying inside of the tubule.
That is like the kind of reasoning that they're going to prey on. The reason being, so again, remember, you have to remember the mechanism by which you actually concentrate urine, okay? The way that you concentrate urine isn't that you stop reabsorbing solute. The way that you concentrate urine is that you reabsorb free water. So having more solute actually has no bearing on the osmolarity. Should have no bearing on the osmolarity. So that's not true. Who wants to give it a shot?
I can try. So we said that in the presence of furosemide, right? So we're saying that the proximal tubule is isotonic. I think that the distal tubule will be more concentrated than in the picture, and
Okay,
the
why?
collecting, because you have blocked your sodium potassium 2 chloride channel, and so they don't have an opportunity to leave. So
Was it isotonic, hypertonic? So let's presume that it was completely blocked. Let's say that you poisoned all of the sodium potassium 2 chloride channels. Would it be hypertonic, isotonic, or hypotonic in the distal
Compared
convoluted
to the
tubule compared to the proximal tubule?
Hypertonic, right?
No, it's actually isotonic everywhere, right? Now, someone tell me why. Someone tell me, why would it be, how about MJ? MJ usually likes to answer these kinds of questions. So MJ, why would it be isotonic everywhere? So again, they could easily, so I want you guys to see the kinds of reasoning you need to be able to do for your exam. So yes, everyone, by the time that they take their exam, hopefully will know that this is isotonic, at least in this group. I hope that all of you guys will know that. What will differentiate students after that point is when they start to manipulate things. So like, just like the question of in nephrogenic diabetes insipidus, what would be the osmolarity here and the osmolarity here? They could also say, in the case of furosemide or giving lots of furosemide, what would the osmolarity be here or here? That's a very fair question. But these are the kinds of questions that you need to be able to answer if you want to have a chance of breaking like 230, 240. MJ, what do you think?
I cannot figure out, but I'm guessing maybe that's because during the DI, you lose
No,
too
we're not
much.
talking about diabetes insipidus. We're talking about furosemide. We're talking about furosemide.
Would it be because you would stop the water getting reabsorbed?
You'd stop. Well, what do you mean? You'd stop the water getting reabsorbed.
So when the salt leaves in the descending loop of Henle, that's when we're setting up our concentration gradient. And as the salt leaves, then the water leaves, and we pretty much lose like the same amount of salt and water.
What do you mean? We lose the same amount of salt and water. Oh, you mean in the
completion of the loop.
You're talking about into the medulla, like in the actual interstitium itself. Sure. Okay.
So the osmolarity is going to be the same, because if you block the NAK2Cl channel, you're not going to have the same concentration gradient set up whereby the water leaves. So the sodium and all of those ions are going to stay in the nephron and in the tubule, but the water is also going to stay. So the osmolarity, like the ratio, is going to be the same.
I think my guess is that if anyone didn't follow it, it would be because of what you said in the last part. The salt and the water, the ratio is going to stay the same. But let me try and help. So I think what Sarah's trying to say is that so you're not able to salt the medulla anymore, right? If you block the ability to have the sodium potassium true chloride channels, you can't put salts in the medulla, in the medullary interstitium, which means there's no driving force for the water to leave in the first place. Do you guys follow? Right? There should be no reason, right? If this didn't happen, if I couldn't move salt in here, there's no reason for this to become more hypertonic. Does that make sense? So if I can't move salt into the interstitium, then I'm not creating a gradient anywhere. Do you guys follow?
Right.
Yeah. So really, this should all be isotonic. If I can't move, if I've poisoned all of my sodium potassium 2 chloride channels, it'd be impossible to move salt. And so remember, it's this gradient, the medullary interstitial gradient, that allows for you to reabsorb water in the first place, and also allows you to create more hypotonic fluid in the distal convoluted tubule. Does that make sense?
Can I ask you a question? So are we talking about it's isotonic compared to the medulla or isotonic compared to the concentrations in a regularly functioning countercurrent?
No. So it'd be really confusing to say relative to regularly functioning countercurrent. No. Like relative to the body, relative to the proximal tubule, relative to the serum. Remember, everywhere in your body is isotonic. The only part of your body that's not isotonic is in basically the renal medulla and this part right here, right?
Get to the distal convoluted tubule and the NaCl channel is working there?
That's a good question. So I think, yeah, that's a good question. I don't think that, because I think that water and salt both go together. So I think in that case, it's an isotonic shift there as well. So I don't think it shouldn't, right? Because this is what sets the osmolarity. This is what sets the gradient. So that shouldn't matter because it's also soluble to water, pretty sure. Because again, this is the rationale for why furosemide, you can't become hyponatremic. Why? Why can't you become hyponatremic if you give someone furosemide, at least in theory? In practice, you probably could, because this would never become perfect. You could never perfectly block the sodium-potassium 2-chloride channels. So you would always still probably have a little bit of a gradient. But if you could perfectly block the sodium-potassium 2-chloride channels, you should not be able to become hyponatremic. Why? Mo, what do you think? Mo was telling me earlier that he knows all the answers to all these questions. We're going to have him explain.
It's because they get to a point where the gradient shifts into the vertical score.
The gradient shifts, what do you mean?
Even with furosemide, you still need like more of the concentration in order to hit smooth. But if you keep getting rid of like sodium, eventually it'll just stop and then it'll switch. That makes sense. So
I'm not sure. I did not follow that actually. What gradient would shift? I don't understand. Okay, let me explain it to you guys. So basically, the reason is that if you don't have remember, the gradient is the entire reason why you can absorb free water. No gradient, no free water reabsorption. Okay, do you guys follow? So the reasoning goes something like I block the sodium potassium 2-chloride channel, which causes me to lose the countercurrent multiplication, which leads to loss of ability to absorb free water, right? So if I can't absorb free water, then I can't dilute my serum to the point where I'm hypernatremic. Does that make sense? I can't make my serum have a lesser osmolarity because I don't have the ability. I can't reabsorb free water. Does that make sense?
Yes.
Cool. Okay, perfect. So
Wait, sorry, can you go back to that picture of the nephron?
Sure.
I just want to make sure that I'm understanding. Okay, so in the thick ascending limb, that's where you're blocking the NAK
correct.
CL channels. And so since you're blocking them, you're not concentrating this middle medulla part. And so with the lack of that concentration gradient here, you're affecting the way free water moves in the descending limb.
Perfect. Yeah, because remember, all I'm doing when I'm doing ADH is I'm putting water channels there. The water could, in theory, move into the tubule, right? It doesn't have to be absorbed out. The only reason that it's absorbed out is because there's a concentration gradient where the medulla is more salty than the tubular fluid.
Yeah.
The only reason why having ADH put aquaporins in, the only reason why water is actually moving out is because you have a high concentration of solute in the medullary interstitium and not in the collecting tubule, collecting duct.
So going back, so for the effect loop diuretics on osmolarity in the proximal tubule, distal convoluted tubule, and collecting ducts. So proximal tubule is isoosmotic, distal convoluted tubule is isoosmotic. And then in the collecting ducts, since you can't move the water back out, you would be hypo.
No, it'd be isotonic. Also isotonic, right?
There was no difference.
Because there's no difference. You can't concentrate or dilute your urine along this entire path. So it should be the same osmolarity everywhere.
Okay.
Does that make sense?
Yeah.
Cool. But you can see how this is like exactly the kind of question that you're going to see on the day of your test. So it happens every time. I get emails. So one of you guys, I won't say who, but one of you guys is taking their test like right now as we speak. One of the people in the group. And I guarantee right now, this person is seeing questions that they've never seen before, like never prepared for. That's true of everyone, okay? And so the people that do well on the exam are the ones that are able to take what they've learned and adapt it to novel situations. So like the question of in diabetes insipidus, nephrogenic diabetes insipidus, or any sort of insipidus, what would the osmolarity be at the different stages, right? Or in the case of a complete loss of the sodium potassium true chloride channel, what would be the osmolarity of the different parts? Those are fair game, even though you've probably never ever seen those questions on UWorld and probably never will. Does that make sense?
I have
You
a
need to be able
question.
to manipulate it. Uh-huh.
I understand that it's fair game for step one. Could that kind of stuff clinically relevant if say I become an internist or something?
To nephrologists, yeah. I don't know that this particular fact. So countercurrent multiplication and understanding the ability to concentrate urine, yes, absolutely. That is very, very relevant. Like whether someone's like hyponatremia is because like you'll know what kind of drugs they're taking, so probably not. Like you would never be like, oh, they're hyponatremic, so it can't be furosemide poisoning. So not in that respect, no.
Okay, thanks.
Okay, so let's talk briefly about azotemias. We didn't talk about this last time, did we? I'm just going to give you some numbers that you should know. So prerenal azotemia. First of all, what does prerenal azotemia even mean? Fayaz, you haven't said anything. So what do you think?
High creatine, high BUN in the blood, right?
Uh-huh. But what does it mean? So you're telling me like numbers, but I'm saying like what physiologically does that mean?
The kidney cannot dilute or get rid of the BUN and the creatine.
I don't know about that. So in general, so kidney failure, like how do we define kidney failure, Vibhu?
Kidney failure, inability to prevent like larger molecules like proteins from going into your urine.
It's actually not how we define kidney failure. Can someone help?
Elevated BUN and creatinine.
Yeah, really it's just elevated creatinine. So why? What is it? But what does that indicate? What are we using creatinine as a proxy for?
GFR.
GFR. So it's filtration. So kidney failure is defined as a filtration problem, right? So if the kidney's filtering less, it means that you are in kidney failure, or at least you have decreased renal function. Okay, so the difference between prerenal azotemia and intrarenal azotemia is that prerenal azotemia, it means that GFR is down because of renal blood flow down. But the glomerulus itself, like the kidney itself, would function fine if blood flow were okay. That's basically what prerenal azotemia is. What does intrarenal azotemia mean?
So if it's intrarenal, then there's going to be a problem with your membrane where you're letting ions through. And
It's a problem with the kidney itself,
right.
which leads to the GFR down. So in other words, if I were to restore blood flow to the kidney, if I were to increase blood flow to the kidney, it wouldn't matter. I still wouldn't be able to filter, okay? So can someone explain to me why would a prerenal azotemia have a low FeNA? Why does that make sense? Let's do it with Shama.
You're getting just less blood to the kidney. It's you're getting less reabsorption of sodium just because there's less going to the kidney.
Wait, what does FeNA mean?
Excretion of sodium.
Yeah, exactly. It's actually that you're excreting less sodium. So you're actually reabsorbing more, right? Because if you think about the actual equation, it's technically clearance of sodium over clearance of creatinine. I think it's clearance of creatinine over clearance of sodium. But anyways, of the total amount that's filtered out, how much is actually excreted? So if it's less than 1%, it means you're reabsorbing a lot of sodium. Okay, so why would that make sense? In a prerenal azotemia, why would your FeNA be low? Chris with a K.
I don't know.
Okay, can someone help? Mo, what do you think? Go ahead.
So you're getting less blood flow to the kidney. So your kidney senses that and activates the RAS system. And so you'd start reabsorbing more sodium.
Yeah, exactly. The basis of the way that you set your intravascular volume is the amount of sodium. Remember we talked about in the beginning, sodium is there to set your extracellular fluid concentration. It's to set the amount of extracellular fluid you have. So the more sodium you have, the more extracellular fluid. The more extracellular fluid, the more intravascular volume. So the whole point here is that sodium sets extracellular fluid. So if you reabsorb sodium, it should lead to intravascular. That's the whole point. Okay. Now, why would in the case of intrarenal azotemia, why would the FeNA be up, or would the urine sodium be up, Shama?
Because you can't reabsorb the sodium easily now because there's dysfunction with the actual glomerulus this time.
Yeah, exactly. If there's a problem with the kidney, if it is with the kidney itself, you're going to have problems all along it. So you won't be able to absorb nearly as much sodium. Perfect. Okay. So this is critical for you guys to understand, right? I want you guys to make sense of it. But again, you have to understand this for your test. Okay. All right. So let's kind of change gears. We're going to talk about hypersensitivity reactions. Okay. So what does a type 1 hypersensitivity reaction actually mean, Chrissy?
So type 1 is when you encounter an allergen and you produce IgE in response to it. And those IgEs like go and attach to your mast cells so that the next time you encounter that allergen, your mast cells are hypersensitized, and then the antigen will bind to the IgE and cause mast cell degranulation.
Yeah, perfect. So basically, like a systemic reaction that's mediated by IgE. But yeah, perfect. You walked through the mechanism quite well. That was good. How about a type 2? What's the difference between a type 2 and a type 3 hypersensitivity reaction? Chris with a K.
For a type 2 reaction, you have the antibody bind to a fixed antigen. That's going to be relevant later when we talk about like linear IF and lumpy bumpy. And then for type 3, you have the antibody antigen complexes floating around, like they bind together and they float around in your body. They deposit in your kidney and your skin and your, the other one. Anyway, they deposit in the body.
Perfect. Yeah, exactly. So it's one is a bind to a fixed antigen versus in type 3, it's a complex antigen antibody complex. Perfect. How about a type 4, Maria?
4 is late sensitivity reaction, so it's T cell.
Yeah, perfect. This is relevant because they're going to ask this question of you give someone a PPD, and if you were to biopsy like someone that had a positive PPD, what would you see? What would be the predominant cell that you would see? What's the answer?
T cells.
Well, yeah, T cells or macrophages. It's one of those two. It's going to be one of the two. Actually, probably macrophages would be the correct answer because they love macrophages on the test. We'll talk about that in a future session about how to spot macrophages and how it can help you answer questions. But the guy, Henry Sanchez, that writes questions for the exam, he talked about like the importance of understanding macrophages. So we'll talk about that. Okay, so good pastures. So good pastures, important things to know. So it's type 2 hypersensitivity. So we're going to talk briefly about trying to use your understanding of the hypersensitivity reactions to understand why they look the way that they do. So in good pastures, it's an anti-glomerular basement membrane, okay? Antibody. It's a type what? Type 2 or type 3?
Type 2.
Type 2. And why is it type 2?
Because it's fixed.
Yeah, it's fixed, right? The antigen, the glomerular basement membrane isn't floating around. So it's a fixed antigen. So you have to know how it presents. So renal failure, so RPGN, basically, rapidly progressive glomerulonephritis. It's very similar in presentation to Wegener's. How do you differentiate it with Wegener's?
The lungs.
Yes. What do you mean the lung?
Upper respiration.
Yeah, so like bloody nose is like something that you would see with Wegener's, but you shouldn't really see it with good pastures. That, and one is ANCA mediated and one is the glomerular basement membrane. And then Wegener's is negative IF. So we'll talk about that in a sec, but keep that in the back of your mind. Okay, so if we were to stain good pastures, if you were to stain the kidneys in someone who's good pastures, what would it look like? Would it look lumpy, bumpy, or linear, and why?
Linear.
Linear. Okay, so why would it look linear?
Along the basement.
Yeah. So basically you have antibodies that are going against the entire basement membrane. It's hitting the entire basement membrane. So it's going to be evenly distributed, right? Not lumpy bumpy. Okay. In general, if you see a linear pattern, you should think good pastures. Like there's nothing else that looks like this, at least for step 1. Okay. So how about lumpy bumpy? If something is lumpy bumpy, what do we know that it is and why?
It's definitely lymphitis.
Yeah. Post-strap or something. So what does it tell us? Why would it be lumpy bumpy? Why would that make sense?
Because it's type 3 and they're just depositing anywhere.
Yeah,
So
exactly.
it's not like uniform. It's just going to be, yeah.
Perfect. Yeah. So if it's a type 3 hypersensitivity reaction, you have these balls of antigen antibodies floating around. Okay, perfect. Who can explain to me why is there in post-immune glomerulonephritis, why does it make sense that well, first of all, what does it mean if it's post-immune?
Means that we don't have antibodies to detect.
Yeah, there's no antibodies that you can detect. And why? Based on the pathophysiology, why would that make sense, Maria?
I actually never thought about that before. I just learned it that way.
So you have to know this fact for step 1, right? The fact that if you were to stain someone's kidneys for antibodies that had Wegener's, you wouldn't see anything. You wouldn't see a fluorescent pattern. You wouldn't see lumpy bumpy. You wouldn't see linear. So the question is why? Who can explain?
I can
Chris.
try.
Sure, please.
So when we think of posse-immune, it's kind of like a lack of an immunity because it have the prefix posse in there. And the antibodies, instead of doing what we think they would do in the other kidney problems, they would activate neutrophils and cause organ damage, and it would manifest in that manner.
So that was not bad. A little vague, but not bad. So it's not that you have lack of immunity. You still have the immune response. The point is that you have this, right? So there's some sort of ANCA antigen. So it's some sort of cytoplasmic antigen. And so you have an antibody against the neutrophil. The point is that that antibody, when you get enough of those antibodies, you can actually activate those neutrophils. It's sort of like it's sort of like having a bunch of grenades. Like your neutrophils are sort of like grenades, and the antibodies are activating those grenades. So you don't really see the evidence of the antibodies there because the antibodies are gone because they've already done their job. Plus, they probably weren't in a large enough concentration to be stained. That would be my guess for why you don't see them. But the point is that you don't have, it's not the antibodies and the antigens they are not directly affecting the kidney. They're affecting the neutrophils, which are affecting the kidney. Does that make sense? Cool. Okay, perfect.
So do some people just have more ALGA and that's why they get these?
I don't know. I don't know that it's understood why. I mean, it's all autoimmune disease, right? Like, why do some people get like autoimmune disease? I don't know. That's like an open question in medicine. What is the pathophysiology of most autoimmune diseases? So I don't know. My guess is that falls under the category of no one knows yet, rather than we in this group just don't know. But has anyone ever told you guys why it's hypothesized that women in childbearing years have a greater amount of like autoimmune disease or like weird antibodies like lupus? So
Like level increases
because what?
at estrogen level.
Estrogen, maybe. So the idea, so again, there are holes in this theory, but this is something that maybe will help you remember that like it's women of childbearing years that are at greatest risk for autoimmune disease, particularly things like lupus. The idea is that because of menses, right? Like all cell death in the body, or at least the vast majority of cell death, is apoptotic, right? Planned, like clean, like cell death. In the case of menstruation, it's different. The cells are actually like, I mean, I would assume it's like necrosis, right? Like you're losing the effect of the estrogen. But the point is that you have spillage of all of this like cells and cell contents. And so the idea would be that your body suddenly recognizes these like intracellular elements and then goes after them with immune responses. It kind of makes sense in the sense that how else can you explain that you would have antibodies against double-stranded DNA, right? Or like some of these intracellular elements that you would never expect the body to ever see. There are holes in that theory. But again, the thing I want you to remember is it happens in women of childbearing age.
Can I say something? Last year, I had one class, and it was about autoimmune diseases. And the doctor said that women that had Raynaud's or Crest syndrome were less likely to develop acute cases of that disease when they were pregnant.
Interesting. Huh.
So
why was that hypothesized?
For example, that specific doctor, she had Raynaud's, and she said that she accidentally got pregnant when she was like 24, 25, and that during that time, and a lot of time afterwards, she didn't have any exacerbation of Raynaud's.
Interesting. Huh. I mean, again, so that would lend. Yeah, I wonder if that's true of other autoimmune diseases as well. That when you're not menstruating. I don't know. It's an interesting idea, right? They will probably never test you on that mechanism per se, but you definitely need to recognize who are the key populations that are going to get autoimmune diseases, and this will help.
Yes.
Okay, perfect.
Another theory is about the estrogen may reduce the apoptosis of self-reactive B cells. That's why there was another reason for the disease come up during
Say that one more time.
The estrogen level increases may reduce the apoptosis of self-reactive B cells.
Reduce self-reacting.
Reduce apoptosis
Oh, I see.
of reactive B cells.
Huh, interesting. Oh, I see. So you're saying that women that are like menstruating or have higher levels of estrogen are less likely to kill the bad B cells that could attack.
Yes.
Huh,
Yes.
that's kind of cool. I want to talk briefly about acute tubular necrosis and nephritic versus nephrotic syndrome, and then I want to go through questions. So I wanted to spend actually as much of this session as possible on questions because a lot of you guys are close to your tests. And I think part of it is knowledge, but I think part of it is like you guys really need to work on is going through questions and analyzing them and thinking them through in the 4 steps. So I want to talk about that. So briefly, let's talk about nephritic versus nephrotic syndrome. Nephrotic syndrome, I think the easiest way to think about nephrotic syndrome is it's an exclusion problem. This would be the pathogenesis to presentation question that I would have you guys put in your cards. But if you think about it, it's a problem of excluding proteins. So proteins leak through the glomerular basement membrane very easily. So because of this, this explains a lot of this sort of, I guess, side effects. So like you lose albumin, so you get anasarca. Anasarca is just total body edema. you lose antithrombin 3, so it's odd, but you're actually hypercoagulable, even though you lose coagulation factors and your PTT is very high. So this is weird, but these are things that you can use to identify nephrotic syndrome or things that they may ask you on your test. And you also lose immunoglobulin, so you're immunodeficient. But the picture I want you to have for nephrotic syndrome is you're just losing protein. It's an exclusion problem. You can't exclude proteins from your urine. Nephritic syndrome is different. Nephritic syndrome is, if you think of the kidney or the nephrons as a bunch of things that are filtering stuff, because we said kidney failure is when you can't filter stuff. Nephritic syndrome is really just you can't filter stuff. So it's basically like kidney failure. So all of the things that you think of for kidney failure are going to be true for nephritic syndrome. So you're going to get azotemia, you're going to get oliguria because things aren't filtering through and you're not making urine, and you're going to get hypertensive. Why would you get hypertensive? Why would that make sense? Sarah, why would that make sense?
So if you're not filtering, for example, sodium through, you're going to have like hypernatremia and hypertension secondary to that.
Yeah, exactly. Because again, I love it. You talked about sodium, right? And sodium sets what again? The extracellular fluid volume. So sodium sets the extracellular fluid volume, which is setting our intravascular volume, because your intravascular volume is 1/4 of your extracellular fluid volume. Perfect. Okay, let's talk briefly about ATN, because it's going to show up in one of the questions. So in acute tubular necrosis, what's the most common cause of acute tubular necrosis on your test, right? When you take your test in a week and a half, what's going to be the lead up for acute tubular necrosis?
I think like it's the pre-renal
Yeah,
problems, like
pre-renal
hypertension.
Yeah, exactly. So why does that make sense?
If you don't have blood going to your kidneys, it's gonna like necrose.
Yeah, exactly, right? Ischemia causes death. Well, ischemia for long enough causes death in all organs, right? So in the case of prerenal azotemia, right, where you're not getting enough blood to the kidneys to allow filtration, you are having ischemia to those proximal tubular cells, and so they're going to die. So that makes sense. So we said the most common cause is prolonged prerenal AKI. And then what's the key finding in the urine in ATN, and how do you make sense of this, Mo? What do you think?
I imagine it would be like low urine.
Nah, that's very non-specific. Prerenal azotemia will also give you low urine output, right? A bladder obstruction is also going to give you low urine output. Can someone give him a hand?
Yeah, so you'd find granular, like muddy casts.
Granular muddy casts. I love it. So this is something that if you didn't know, you should write down. This is one of those things that you should like tattoo on your wrist so that they can't like take it away from you. Like this you can bank on it being on your test. Okay, so why is it granular muddy casts? Why does that make sense?
So you're having necrosis of the cells in the tubules, and so
where in the tubules? This is also a step one question. Where in the tubules are you going to get necrosis?
So it's the proximal and then thick ascending.
Yeah. They're going to ask if
first
it's
season.
yeah. And MJ, why does it make sense that it's in the proximal tubule? Like that would be particularly prone to it?
I think maybe that's because more solids pass through that, and it's the first place.
Yeah, exactly. It's where, like, if they ever ask you, like, where does the majority of absorption of X happen? 9 out of 10 times it's going to be the proximal tubule, meaning the majority of everything is absorbed in the proximal tubule, which means it's highly energetically active. So it needs a lot of ATP. So it makes sense that would be the most sensitive to ischemia. Okay, so those cells die. And so wait, why do I get muddy brown casts?
So the cells die and they get sloughed off into the tubules, and they just take the shape of the tubules, and then they get pushed out and they still look like that.
Exactly. So when I was younger, we had this laundry chute in my room that was like the only laundry chute to the basement. And so I thought I would be clever and try to put like all of my laundry down in one go. So what happened is it got blocked up, as you would imagine. But then like eventually, as I was able to get the clothes down, like they, for a brief period of time, took the shape of my laundry chute. So that's essentially what's happening in ATN, right? The cells are sloughed off just like my clothes, my dirty clothes, and then they get stuck in the tubule. So they block anything else from going down. So that's why you're oliguric. And then eventually when they pass, they take the shape of the tubule, just like my clothes took the shape of my laundry chute. Does that make sense? So they're going to sometimes ask about the different phases of ATN. And Chris, to your point, this is actually very clinically relevant because you need to be aware of this, because when people have ischemic ATN, they're going to end up peeing a ton, and you need to know why. Okay, in early ATN, it's the oliguric phase. So why would it make sense that you would be oliguric? Well, we already talked. We already said you're oliguric because the tubules are blocked because you've got those dead proximal tubular cells that are clogging them, just like in my laundry chute. Okay. So your potassium is going to be high because you can't excrete any potassium, and you're going to be hypertensive because, like Sarah was saying, you're not going to be able to get rid of any sodium either. Okay, so the one that's difficult to understand is the late ATN, or the non-oliguric phase. So you're going to be polyuric and you're going to have low potassium. So can someone tell me why that would make sense that you actually, it's odd, but in ATN, you're like, at some point you're going to start peeing out a ton. So how about Lindsay? Can you tell me why it would make sense that you're suddenly like peeing out a ton and your potassium's low?
I think that it may be in response to trying to deal with hypernatremia.
Oh, so you think it's a response? Not really a response so much. Can someone help?
Can I?
Please.
Yeah. So let me go with your laundry chute analogy.
I love it.
You block your laundry chute, and so your attempt to solve it is you make 3 other laundry chutes, and then all of a sudden your original laundry chute unclogs. So now you have 4 laundry chutes all shooting out.
That's nice, but you don't actually make more nephrons. So it's actually not that. So the reason is because you're making more, you're regenerating the cells, right? So it's sort of like, so we're gonna have to get rid of the laundry chute analogy at this point because it's not gonna help you understand it. So the reason is that the cells themselves, like, so a mature proximal tubular cell, if it's like at the top of its game, it's gonna be able to reabsorb a ton of stuff, potassium, other solutes. Now, if it's an immature cell, would you believe me that it's not going to be able to reabsorb as well as a mature cell? Yeah, exactly. This is the same. Yeah, this is the same principle for like why kids, when they have like a GI infection and their GI tract like sloughs off, this is why they'll still have watery diarrhea for a while, even if the organism's been cleared, because the cells themselves are immature. So in this case, the proximal tubular cells are immature, so they can't reabsorb stuff as well. So because they can't reabsorb stuff as well, they can't reabsorb solute, so you're going to lose water because water follows.
Alec, I just love this explanation because these answers me a huge question my customer asked me.
Perfect. I love it. That's fantastic. I'm really glad that you said that. Yeah, because right, the explanation, like, you can make sense of all of this. The reason why I want you guys to see as many explanations like this as possible is because I want you to see that it's possible to learn all of medicine like this. So, but you're also going to lose, so you're going to lose solutes and lose potassium. Make sense? Okay. We're going to talk briefly about aldosterone escape. So what is aldosterone escape?
So when you have a lot of fluid in your system, like high blood volume, your atria sense the stretch, and then they secrete ANP, which helps
Yeah. In other words, natriuresis. So it's funny. My wife is Korean, but she studied in Austria. So she speaks German because she studied violin in Austria for like 5 years. There's like a handful of things that she says that are kind of odd. One of those things is natrium. So like we were talking about something and I was like, oh, it's like really salty. She's like, yeah, well, the natrium is really high. I was like, excuse me? Like, I don't understand what you just said. She obviously meant sodium, but I guess in German they say natrium or something, some equivalent. So natriuresis means like sodium loss. Does that make sense? That's why I brought that up, because like we still use the root. Okay, so the reason why we're going to talk about aldosterone escape is because the reason why it even matters, because like I was like, why would we even talk about this? So the idea is that in the case of primary hyperaldosteronism, do you get a lot of edema? No, you don't. You don't get a lot of edema. And it's weird, right? Because you'll present with hypertension. So you're presenting with signs of high intravascular volume, but it's not like you're absorbing so much sodium that you're expanding your extracellular fluid that you're getting edema, right? It's odd, right? Like, why, right? Your aldosterone is high. Why wouldn't you have edema? It's kind of weird, because in secondary hyperaldosteronism, like in heart failure or in cases where the kidney is hyperactive because you have renal hypoperfusion, you do get a lot of edema, right? Heart failure, they present with tons of edema by this mechanism because you have high aldosterone, you have high RAS because you're reabsorbing fluid. So it's odd. This is the odd duck, okay? And so no one really understands fully why. In one case you do have edema, in the other case you don't, but it's thought to be at least mediated in part by ANP. So ANP is released, as Chrissy has sort of hinted at, because of stretch of the atrium. So when the atrium stretches, you release ANP, and ANP causes you to pee out salt more, natriuresis. So that it counteracts the amount of salt that you're reabsorbing with aldosterone. You're peeing out that salt. So you're at you reach a steady state. Cool. So I get this question a lot. I wanted to just talk about it briefly to all of you guys because this comes up a lot. So what is aldosterone escape? It is the mechanism that's posited for why in primary hyperaldosteronism you don't have a lot of anemia. Okay, perfect. So next, let's talk about some questions, shall we? So I'm actually going to stop the recording here. So today I want to switch gears and talk about endocrinology. Okay. So specifically diabetes mellitus and thyroid hormones. These are probably two of the most important conditions that are in endocrinology, and I think that they can tell us a lot about other diseases as well, which is why I wanted to start with these. We'll talk a little bit about diabetes because we've covered it in other sections, particularly in the biochemistry section, but we'll spend the majority of today talking about thyroid hormones. So let us get started. So remember, these are the pathogenesis to presentation questions. These are the things that you are supposed to understand. And if you understand them, you'll understand the vast majority of what it is that I talk about in this lecture. So at the end of every lecture, at the bottom, I post these along with the answers so that literally all you have to do is watch the video and then copy and paste the answers into your cards. And as long as you've done the work of doing your cards every day, you will never forget the information in these cards. And if you read the article that I released last Sunday, you'll know that the NBME cares most about your ability to apply information. This is applied information. And so if you understand this, it means that you are able to apply it in some way that's clinically relevant, which is exactly what they're asking you to do on all of your NBMEs, all of your USMLE Step 1, Step 2, Step 3, and shelf exams. So after this is your goal. You want to understand all of these. Okay, so let's get started. So let's start with Alex. So Alex, what exactly defines diabetes mellitus?
I guess insulin dependence or maybe for glucose control.
Yeah, it's the second. So it's interesting because it's like we think of the mechanism, but really it's just high glucose, high blood sugar, right? That's it. It's defined operationally is how it's described. So there's different cutoffs, right? So fasting glucose above 126, 2 times, or non-fasting above 200, 2 times, or A1C above 6.5. Okay, so for diabetes type 1, Catherine, what is the general pathophysiology, just generally speaking?
Okay, so I guess a decrease in insulin causing an increase in glucose.
Perfect. Yeah, exactly. So it's usually autoimmune destruction of the pancreas, which leads to a relative insulin deficiency, which leads to too much blood sugar. Great. So Danielle, what would be this is a harder question. So what's the general pathophysiology of diabetes type 2?
So for type 2, you have insulin resistance. So your body, like the cells, can't utilize insulin and uptake glucose. And then your body thinks that it's not producing insulin because your body is not registering it. So it overproduces insulin. And then that causes, like, I'm trying to think of the word, like destruction of cells. What's that protein?
Amyloid.
Yes, amyloid. Sorry,
Yeah,
having a brain
exactly.
fart. Yeah, like a production of amyloid, and that's destructive to cells.
Yeah, that's actually pretty good. I don't know that I would say that this body doesn't recognize that it's producing insulin. I guess probably the more accurate way of saying it is that because of the insulin resistance, so because of the insulin resistance, you have to overproduce insulin in order to bring the blood glucose down, right? And so amylin, one of the byproducts of too much amylin production is amyloid, which gives you beta cell dysfunction, which gives you a relative insulin deficiency and hyperglycemia. So again, they both are ending in blood sugar that's too high. We'll talk a little bit more about what amyloid means because this is something that was really confusing to me for a while. So we have some diagrams that we can explain. So Elaine, can you tell me, would you produce more or less insulin in early diabetes type 2 than a normal person?
So you would produce more insulin than a normal person?
Yeah, why?
Because like in the previous explanation, it says that in type 2 diabetes, you have an insulin resistance. So your body tries to compensate by overproducing that insulin.
Yeah, exactly. So it's interesting, right? Because like you wouldn't necessarily think of, like I never really thought of diabetes type 2 as being like, oh, I'm actually making more insulin than normal, but that's actually what you see. And even like pre-diabetics, right? When they say like you're pre-diabetic, that's really probably where the insulin production is highest. And so the point is that over time, eventually, because of that amyloid production, you get beta cell dysfunction, and that causes you to not be able to produce enough insulin. Perfect. So Elisa, what exactly is amyloid?
So to my understanding, it's basically misfolded protein, and you can have that from all kinds of diseases where protein ends up precipitating in different organs. And usually proteins are being degraded by the proteasome, but in case of amyloid, that protein isn't degraded correctly and ends up participating.
Good. That's actually surprisingly good. Can you tell me why, Elisa? Like why exactly does that happen? That you get this accumulation of misfolded proteins?
Why would it has to do something with a general overproduction of that protein, that I guess I could imagine that reading everything at a time isn't sufficient enough.
Yeah. So the way that I understand this, the way that like my reading of this is that during protein synthesis, right, there's always some fraction of proteins that are misfolded. That's just a natural thing. Our body takes advantage of this by using MHC1, right? So the proteins that come from the proteasome are loaded into MHC1, if you'll recall from immunology. And because it's sampling, because some fraction of all the proteins that you make are going to be misfolded and need to be ubiquitinated and broken down, right? So those fragments are loaded to MHC1, and that it's loaded into the outside of the cell, and so that gives CD8 cells a sense of what's going on inside the cell. So we take advantage of this, but some fraction of proteins always misfold. So they're ubiquitinated, and then they go to proteolysis, the proteasome. You need to remember the ubiquitination proteasome. For some reason, they just love that for step one. They just love it. Ubiquitin proteolysis, like is a disproportionate number of questions about the proteasome. You just have to remember that that's all. That's like oftentimes what they're asking you. So what you also need to know is that there's some parts of proteins, right? So proteins are often made up of what are called peptides, right? So peptides are just sequences of amino acids. And so oftentimes you'll put together these peptides into proteins. And so some part of them can't be broken down sometimes. So the hydrophobic part is a part that oftentimes can be broken down. And so those things will aggregate. They will form, they will clump. And it kind of makes sense, right? Because if something isn't soluble, if something isn't dissolved in the blood or in the cell, it would make sense that a protein wouldn't be able to necessarily degrade it, right? Something like that solid that's inside of the cell. So in simple terms, if I were to explain this, I would say that a misfolded protein needs to be broken down, right? So it's ubiquitinating, needs to be broken down. However, not all the parts of the proteins can be broken down. Those parts that can't be broken down will accumulate and they'll bind to each other to form amyloid. Does that make sense? So the question is why is it so bad? So Jason, why is amyloid so bad?
I would say because it can be deposited in like tissues and cells where it can obstruct natural physiological processes.
Perfect. Yeah, that's like a great med student answer. Big words like physiologic process. That's good. Yeah. Yeah. It just causes cells to dysfunction. Perfect. So makes sense, right? Because it's hydrophobic, so it would precipitate. And so really, let's walk through the mechanism of how amyloid would form. So we've got a protein, right? Proteins are composed of different components. Usually, oftentimes, they're composed of different polypeptides, although sometimes a protein could be just a single polypeptide. But let's say that there's a protein and there's a part that you can degrade in the proteasome and there's a part that you can't. So some fraction of proteins undergo misfolding. Happens to even the best of them. And so they get ubiquitinated. When they're ubiquitinated, that sends them to the proteasome for proteolysis. And in proteolysis, you can degrade the part that's degradable. However, there's some part of some proteins that can't be degraded. Not all proteins, but some proteins. And so what happens is that, because the question really is like, why do you see amyloid in protein overproduction? Calcitonin and medullary carcinoma, you have the AA amyloidosis that you get in chronic inflammation, right? Like, why? The reason is the way that I understand it is that this happens for those proteins, at least to some degree. But when you overproduce the protein, you just have a lot more of it, right? So if you have more protein synthesis, when I have more proteins, a certain fraction of them are going to misfold. They're going to undergo ubiquitination. Those are going to undergo proteolysis. And then you're going to degrade the degradable parts, the proteolyzable parts. So what happens is that when I overproduce protein, so in the case of diabetes type 2, right, if I'm making a ton of insulin, which also is going to be released with amylin, some of the amylin is going to misfold. Some of the amylin is going to have to be ubiquitinated. Some of the amylin is going to undergo proteolysis, but I am going to be left with the non-degradable parts of that amylin over time. And so the more amylin which is released with insulin, right? So the more insulin and amylin I produce, I'm actually just speeding up the degradation, or I'm speeding up the loss of my pancreatic islet cell, right? Because one of the questions is like, why, when the type 2 diabetes, why was I able to make a lot of insulin in the beginning, but why did that ability decrease over time, right? And this explains why in a very, very simple mechanism. Question so far, this is something that like I didn't understand until, honestly, probably residency or after. It wasn't like I didn't understand the general mechanism of amyloidosis for a long time. So I'm sure that I didn't explain this perfectly. Questions, concerns? All right, well, let's see how I explain this. So Maliha, so absent any contraindications, what's the typical first-line drug for diabetes type 2?
Metformin?
Yeah, perfect. Yeah, metformin. Great. So Manny, given the pathophysiology of type 2 diabetes, what's the mechanism of action of metformin, and why would that sort of make sense, Manny?
So I guess what I know is that it's the only drug that I remember that reverses, or I guess works on the actual mechanism of type 2 or pathophys of type 2 diabetes, which is insulin resistance. So it decreases insulin resistance, and I think it has something to do with gluconeogenesis. Maybe.
Yeah.
Does it increase glucose?
Well, if I was trying to think, okay, so you can think this through, right? So if I was trying to control, so diabetes is high blood sugar, diabetes mellitus by definition. So
You don't want to make more glucose.
yeah. So what effect would it have on gluconeogenesis?
Probably would decrease the liver making more glucose.
Exactly, perfect. And that was a Nature paper in like 2014. It's a big deal. They figured out that one of the mechanisms was decreased liver gluconeogenesis. Because it's still not entirely worked out. There's like a ton of different mechanisms, but that are posited. Maybe it acts in the GI tract, but they know that at least part of it, it seems to work in the liver. It's pretty cool. Yeah, so you decrease glucose production, and so you would need less insulin. So it actually works really well. So Marco, would metformin increase the rate of decay of the pancreatic islet cells? Why or why not?
Oh, it will not, because it controls the gluconeogenesis of the liver. So metformin is considered a fantastic drug for the diabetes type 2.
Yeah, it really is. It really is. Theoretically, you would even think that it might slow the progression, right?
Yeah.
If there was less insulin that were needed, if at least part of the mechanism of progression of type 2 diabetes is that you have islet cell dysfunction because you're overproducing insulin and amylin and producing amyloid as a byproduct, then yeah, I actually think it would be better. Great. Mashoud. So after metformin, what's the typical second-line drug?
It'll be sulfonylureas.
Yeah, sulfonylureas. Perfect. So Natalie, using the pathophysiology of diabetes type 2, can you explain the mechanism of action and how this would fit in?
So sulfonylureas, I believe they inhibit the potassium channel, allowing for more calcium to come in and then insulin to go out. Is that the right way?
Boom. Yeah. Well, so walk me through. So how would that work? So if I close potassium channels, what effect is that going to have on cell membrane depolarization?
Well, it's going to cause the cell membrane to remain at a negative action potential, because then the calcium will come in because it'll want to go towards the negative.
Not quite. So calcium wanting to come in is irrelevant in the sense of like whether it comes in or not, right? Calcium will come in if the calcium channels are open.
Okay.
Right. In other words, if I were to hyperpolarize the cell even more, in other words, if I were to make the inside of the cell even more negative, you're not really going to have that much more calcium come in. That's not the mechanism that drives calcium in. The mechanism that drives calcium in is just depolarization of the membrane.
Okay, and then that causes the insulin release.
Well, that causes calcium to come in.
Okay.
Right. So
and that calcium allows for the binding of the insulin vesicles. Correct?
Exactly. Yeah. So snare and snap proteins, right? The things that are cleaved by, well, you tell me actually. So do you know what cleaves snare proteins? That's a microbiologic protein.
No, can't think of it.
Botulism.
Oh,
the botulinum toxin, right? So it prevents, right? So acetylcholine, right, which activates nicotinic receptors at neuromuscular junction, is in vesicles, and the vesicles need calcium to activate the snare and the snap proteins. So they will botulinum toxin cleaves those. I think it's one of the snap proteins, but something in that complex, and it prevents the release of acetylcholine, right? But it's a calcium dependent mechanism. So the calcium influx causes the release. So yeah, so you have you close the ATP-gated potassium channels, and that causes depolarization of the cells. That causes, I didn't say it here, but that causes calcium influx, and ultimately that causes insulin release. I don't want to get too far into that mechanism. If you guys don't remember it, that is covered in the biochemistry lecture. So look for the lecture on glutamate dehydrogenase deficiency, glutamate dehydrogenase. I think it's a hyperactive gradation. But yeah. Okay, so Paula, can you tell me, would sulfonylureas increase the rate of decay of the pancreatic islet cells? Why or why not?
I think they would, because they push you to release more insulin, and I think that would probably increase the insulin production.
Yeah, exactly.
And so
right?
increase the amyloid.
Yeah. So unlike metformin, which decreases my glucose production, right? Sulfonylureas go on the opposite end. They're just trying to increase my insulin production. The problem is that, again, part of the problem with type 2 diabetes is that we are overproducing insulin, which is causing overproduction of amylin, which is causing amyloid production, which is causing the beta cell destruction in the first place. So by the time that you're on sulfonylureas, you're already essentially you're kind of like flogging a dying pancreas. Right? Like, I imagine like an old horse and carriage setup, and you're just like, the horse is like dying, but you're like just beating it to try to get it to the gas. And it doesn't end well, as we will see.
Sounds disturbing.
I know. So imagine that next time you see sulfonylureas. So Carolina, so after sulfonylureas, what typically is the next step in pharmacologic management?
So after sulfonylureas, at that point, the pancreas is dying, so you'd go to insulin.
Yeah, usually you go to insulin. Again, like there's all these like second and third line things, and maybe there's something else, but in general, this is the typical steps. So you start to give them exogenous insulin. So Sebastian, if you are using the pathophysiology of diabetes type 2, what's the significance of getting to the point of using exogenous insulin for glucose control?
Well, basically you start with the sulfonylurea, right, to make more insulin as well as amylin. So you destroy your pancreas, basically, specifically beta cells. So you need insulin, exogenous insulin, because you can't make insulin yourself. So
perfect. Yeah, exactly. So if we think of, right, this is a long explanation, but if you think of like sulfonylureas as sort of like flogging a dying horse, the horse is like kind of dead by the time that you're using insulin. Like it's not fully dead, but it's like getting there. And so you now need to bring in outside insulin to help it along, right? Because there's no way that you are able to produce enough insulin from your islet cells. So perfect, nice. It also explains, I mean, so like you can also use this to understand why, for example, I didn't talk about this in this lecture, but why, for example, metformin doesn't cause weight loss, but the other drugs do, right? Because again, insulin is like the whole basis of keto diet and Atkins and low carb is basically because insulin causes you to prevent lipolysis, right? Because insulin blocks hormone-sensitive lipase, right, which is what breaks down fat in your adipose tissues. And insulin increases the activity of acetyl-CoA carboxylase, which is the key regulated step of making fatty acids. So in other words, insulin causes you to not break down fat and to make fat, right? So metformin, guess what? Doesn't cause you to increase insulin. If anything, it probably decreases your insulin. And so it doesn't cause any weight gain. Guess what does cause weight gain? Phosphorylureas, right? So you can use the mechanism, right? So again, they'll test you on related things. They might not test you on exactly this thing that you've learned, but if you understand the mechanisms, you will be able to use that knowledge in a question that's related as well. All right. So questions before we move on, because we are going to move on to the HP and organ axis next. Things that I didn't explain well. All right. Okay. So next we're going to talk about the HP and organ axis, right? So it could be the HP thyroid axis, HP A axis. So the general way that you have hormonal control in your body is that you have the hypothalamus, which releases some releasing hormone, right? So TRH, right? Thyroid releasing hormone, let's say, for example. It acts on the pituitary, the anterior pituitary should be, and that releases a stimulating hormone like TSH, which works on some sort of end organ, right? Like the thyroid or the adrenal cortex or something. And then you release some sort of hormone, which then inhibits the upstream things, right? Like it'll inhibit the pituitary and the hypothalamus, for example. Okay, so that's the very like 20,000-foot view of how the endocrine systems, basically most of the endocrine systems work. Okay, so let's start with some terminology. Alex, can you tell me what exactly does it mean to have a primary endocrine disorder?
So like primary and secondary is talking about like where the disorder is.
Perfect.
So primary is, sorry, I'm blanking. I think primary is the organ itself.
Perfect. Yeah, exactly. And secondary would be where?
Secondary would be like anything downstream of the organ.
Downstream be actually upstream. So primary means it's a disorder of the end organ itself, right? So if I said someone has primary hypothyroidism, Catherine, what would that mean?
Okay, so hold on, let me think this out. So if somebody has primary hypothyroidism, okay, so I think like autoimmune or Hashimoto, I think a decrease in T3, T4. So it would mean like, so low thyroid hormone levels and an increase in TSH. So
well, let's take a step back. So big picture, what exactly I'm saying, like, so primary, we said a primary endocrine disorder is a problem in the end organ itself, right?
Okay.
So the end organ in hypothyroidism is the thyroid gland.
I'm sorry, are you asking me a different question? Okay, so the end organ is the thyroid, right?
Yeah, exactly. So if it's primary hypothyroidism, like where is the problem? Is it in the thyroid?
So you'd have
Uh-huh.
right, it'd be in the thyroid, so you'd have a decrease in thyroid hormone.
Perfect. Yeah, exactly. But in other words, it's not a problem in the pituitary and it's not a problem in the hypothalamus.
Oh, okay.
Right.
Okay, I understand. Yes.
So this is an important distinction, particularly for step one, because they will ask you these sorts of definition questions. Again, they won't ask you like, what is the definition of primary hypothyroidism, but they could ask you, and they do ask, like, what would you expect to see in terms of TSH and TRH in primary hypothyroidism? So yeah, so problem in the thyroid hormone itself. So Danielle, what would secondary or tertiary endocrine disorders be?
So secondary would be like what's occurring at a different source, but affecting the organ itself, like affecting
Which
how
source?
be like
Wait,
an ectopic source.
So
maybe
now
more
you're
like-
using like general language, right? Secondary meaning like some other place. That's not what, so endocrinology is very specific terminology here. And it's important to know. So secondary refers to what?
Like I'm thinking of like, I guess for like an example, like,
It's the pituitary.
okay,
So in other words, the organ that is just upstream of the end organ itself.
okay.
Right. So what would a tertiary endocrine disorder be?
Would that be like another source? Like a cancer or something like that?
So it would be one step up from the pituitary, which is what?
Like the hypothalamus?
Yeah, exactly.
Okay.
Perfect. Yeah. So again, these are very specific meanings, and like very few people actually know this. I'm actually like, it's again, because I don't think they teach you guys definitions. So secondary means is for endocrine disorders, right? This is just endocrine disorders. If I say that like someone has hypertension secondary to blah, 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 I don't mean it's in the pituitary, right? This is specific to endocrine disorders. So but if I say someone has secondary hypothyroidism, I mean that there's a problem with the pituitary. And if I say that they have tertiary hypothyroidism, I mean that they have a problem with the hypothalamus. Those are one and the same, okay? So let me make this very clear, right? So primary organ dysfunction happens at the end organ itself. Secondary organ dysfunction, right? Secondary hypothyroidism, let's say, happens in the pituitary. And tertiary happens just upstream of the pituitary in the hypothalamus, right? If you're having like a light bulb moment, you're not the only one, because I've seen a lot of people. The reason I know this is an issue is because I do NBME questions with students, and this is a question that gets a lot of people get wrong, and it's really simple. It's like 3 points on your test. So again, primary, end organ, secondary, pituitary, tertiary, hypothalamus. Only for the HP end organ axis, right? If I say something is like secondary, hypertension secondary to something, I don't mean it's in the pituitary, right? That really is a general source. It could be from something general. But secondary is a very different meaning when it comes to endocrinology. Okay, so let's use some of this stuff. Elaine, can you tell me, using the definitions, if someone had primary versus secondary versus tertiary hypothyroidism, what would the TRH, the TSH, and the T3, T4 levels be?
So in primary hypothyroidism, you would see decreased T3 and T4 and elevated TSH.
But the TRH?
TRH would also be elevated.
Boom. Yeah, exactly. Why?
Because the dysfunction is in the thyroid and not in the pituitary or in the hypothalamus.
Yeah, that's true. But why mechanistically? Like, there was like there's really only one skill that you really need to understand about endocrinology, and it's this. You need to understand feedback inhibition, right? You need to understand that the hormone is going to suppress the hypothalamus and the pituitary, okay? So
Okay.
if I have primary hypothyroidism, why would I have high TSH and high TRH? Using the concept of inhibition, feedback inhibition.
Because it will suppress the pituitary and the hypothalamus?
Well, okay, so I'm making the problem with hypothyroidism is I'm making more, too much, or too little thyroid hormone.
Too little.
Too little, great. So if I have less thyroid hormone, am I going to suppress my pituitary more or less?
Oh, you'll suppress it less to increase.
Yeah, exactly. So so again, where it gets complicated, right? It's a double negative. Pressing pituitary less. In other words, I'm disinhibiting it. Another way of saying. How much TSH am I going to make?
More.
More. Boom. Exactly.
Yeah.
So let's use the same example with the hypothalamus, right? So if I have primary hypothyroidism, I'm going to make more or less T3, T4.
You're going to make less?
Less. Exactly. So if I make less T3, T4, what effect is that going to have on my hypothalamus?
You will increase the amount of TRH.
Good. Why?
Because you are T4.
Because you're what?
Because you're making less T3 and T4. So you are disinhibiting the hypothalamus?
Yeah, exactly. Because normally T3, T4 inhibits the hypothalamus. If I have less T3, T4, I will cause less inhibition of the hypothalamus, which means I will produce more of the TRH.
Okay.
Cool?
Cool.
Does that make sense?
Yeah.
Okay. I should have done a better job of explaining that. So, okay. But yeah, so I don't want you to think like, oh, just because the problem is, in the end organ, therefore like the upstream things are going to go up. No, you need to understand the mechanism. And that's what I didn't do a very good job of explaining. So thank you for pointing that out. Elisa, how about secondary? What would it be in secondary? What would the TSH, TRH, and T3, T4 levels be in secondary hypothyroidism, Elisa?
So in secondary, the TRH would be increased while TSH and T3, T4 would be decreased.
Boom. Why?
So I'm lacking feedback of my end organ. And that's why my tertiary organ that's functioning is increasingly stimulating the secondary organ that's defect due to any reason.
Yeah. So in other words, if I have a pituitary problem and decreasing my production of TSH, right, it also means I'm going to produce less T3, T4. So if I have less T3, T4, I will disinhibit the hypothalamus and in theory, the pituitary. Problem is that I have a problem in the pituitary. So even if I disinhibit the pituitary, I can't increase my TSH. So TRH is up, TSH is down, T3, T4 is down. Great, exactly. And then let's go to Jason, finally. So tertiary hypothyroidism, what would be the lab values, Jason?
Is this me, Jason?
Yeah.
Okay. In tertiary, let's see, let's go in order. We're going to have an issue with the hypothalamus.
Great.
And so, okay, this is great. So that's going to be where our issue is. And so our TRH is going to be low. Our TSH, would that be elevated? Because you wouldn't have the...
Oh, it's interesting. No, not usually. I don't think so. I see what you're saying.
It would be decreased.
Because it's sort of hard.
Yeah.
Well, my TRH, I can't stimulate my pituitary, but like I'm also going to be inhibiting it from this now. I think the TRH wins in this case. So if I don't have TRH, I'm not going to stimulate the pituitary.
All right. So that everything should be decreased.
Yeah, exactly. Everything is low. Yeah, exactly. And no matter how much I disinhibit these other things, it's not going to matter because for the pituitary, I don't know.
Okay, yeah, because I was thinking, okay, the pituitary.
Yeah, it's a fair question.
It's stimulated because it's not. Yeah, but I see then how everything would be decreased then.
Yeah, but it's the TRH that matters. Good, perfect.
Okay,
nice. So Litzel. So how about if I had primary versus tertiary hyperthyroidism? What would that look like? Oh, geez. You can do this, man. You can, again, like all these things, as long as you understand feedback inhibition and the definition of primary, secondary, and tertiary, whatever organ dysfunction, like most questions will make sense to you in endocrinology. There's really not that much, honestly, to understand conceptually.
Can you repeat the question, please?
So explain to me what the TRH, TSH, and T3 and T4 levels would be in primary versus tertiary hyperthyroidism.
Oh, okay. So hyperthyroidism. Okay, so
in primary hyperthyroidism, then you would have T3 and T4 increased, and then the TSH and the TRH would be decreased. And that's primary. And then tertiary, you would have, oh, wait, it's up there. Okay, so you would have T3 and T4 increased, and then TSH increased as well, and TRH increased too.
Boom. Yeah, exactly. Well done. Yeah. So in primary, right, I'm making a ton of hormone, a lot of T3, T4. That will cause an increase in inhibition of the hypothalamus and pituitary, so my TRH and TSH would be low. However, if it was tertiary, I would have a high TRH level, which means I'd stimulate my pituitary like crazy and make extra TSH. Extra TSH means I'm going to have extra T3, T4. So they're all high in tertiary. That's good. Well done. See, it's really like at core, it's not, as long as I explain it reasonably well, it's not that bad. So the key is did I explain it well? So questions so far, and I know that I didn't do a great job. Okay, well, you may just be being polite. Okay, so Luis, tell me, what are the two, like, this is a read my mind question, but basically, what are the two major things that you need to make thyroid hormones? It's essentially two things, and that's it. It's like a number of chemical reactions, but what do you see there?
Okay, yeah. Two major things that you need to make thyroid hormones is iodine and TSH.
That's okay. Yeah, it's a bad question on my part. So you need tyrosine.
Oh yeah, tyrosine,
which is the amino acid, and you need iodine, which is what you said. Yeah, I mean, yeah, you could argue, yeah, you need TSH and TRH and all that other stuff too. But I mean, like in actual ingredients that go in to make thyroid hormone, it's essentially just two things: tyrosine and iodine, and then you do a couple chemical modifications, but that's essentially it. So Maliha, so use the fact that it's made from tyrosine and tyrosine in particular, to explain where the thyroid hormone receptor is in the cell.
It's in the cytoplasm.
Boom.
Or like intracellular.
Yeah, it's intracellular. Good. Why? Why is it intracellular?
Because tyrosine is a nonpolar amino acid.
Yeah, exactly. Tyrosine is a nonpolar amino acid. Yeah. So tyrosine's nonpolar. So if you remember, so it would make sense that the thyroid hormone would also be nonpolar, right? Because it's made essentially from tyrosine. And so polar substances don't cross cell membranes. And so anytime that you have a polar substance, it will have a cell surface receptor, right? Insulin is a peptide, relatively polar, it's found at the cell surface receptor. Catecholamines, polar. I don't know if they're polar, but they're certainly, they might just be too large, but they are also on the cell surface. The only things that have intracellular receptors are nonpolar substances because they can cross cell membrane. So they enter the cell and then they go into they find the receptor inside the cell. So Manny, can you tell me what other hormone class has intracellular receptors?
I think steroid hormones.
Steroid hormones. Yeah, exactly. And why are they hydrophobic?
They're derived from hydrophobic substances, so they can cross the plasma membrane.
That is true, but which substance?
Is it cholesterol?
It is cholesterol. Yeah, exactly. So steroid hormones are made from cholesterol. And as anyone can tell you who's eaten bacon and tried to clean it up afterwards, cholesterol is nonpolar. Right? It does not dissolve in water. There was an article recently, I don't remember, it was like the New York Times or the Wall Street Journal. There was this article about bacon. Now everyone is like when they make bacon, because like bacon is like, it's like there's a resurgence of people eating bacon for, I guess, a variety of reasons. But everyone is putting even though everyone knows that they're not supposed to, they're putting the bacon grease in the sink, and it's precipitating, right? Because it's nonpolar, and so it coats all of the pipes, and there have been like just masses of bacon, or basically animal fat, that because it's nonpolar, it all just like aggregates together. And so in like water treatment facilities and like sewers, like they've had to dislodge just these gigantic, like people-sized fat clobs. So cholesterol is nonpolar. This is all to say cholesterol is nonpolar. And so it will also cross cell membrane. So steroid hormones also work inside the cell. They don't have surface receptor. And Emily has like, ew, that's disgusting. But I tell you the story because it will stick with you, right? Just like the sulfonylurea is flogging like your dying pancreas, you will remember that steroid hormones are made from cholesterol and that they will that they do not precipitate, or that they do precipitate in water, they don't dissolve in water. And so that's why A, they cross cell membranes, and B, they will clog all of your pipes. Jason says, now I know why my mom always poured the grease in the jar after cooking and not down the sink. Yeah, exactly. I know. Yeah, it's one of those things that's like, you can always say like, oh, it's like, okay, yeah, just like this one time, but it is bad. Because even if it doesn't clog up your pipes, like the downstream effects for the system is pretty bad. All right, so Marco. So what exactly is thyroglobulin? Like, when we say thyroglobulin, like what exactly is it? Generally speaking, what is it?
Okay, so thyroglobulin is a protein that's produced by the follicular cells and used within the thyroid gland.
Good. Why? Like, how is it used? And what's like the major defining feature of thyroglobulin? What's the major what? Sorry? Like defining feature. This is a bad question on my part.
It's a long protein. Is that it?
Yeah, it's a long protein and it has a lot of what amino acid?
Oh, a lot of tyrosine.
Oh, exactly. Yeah. It's a really long protein and it has a ton of tyrosine molecules.
Yes.
Right? 134 to be exact. Crazy. Right? It's just really long and has a bunch of tyrosine. Why? Because guess what thyroid hormone is made out of? Tyrosine, right?
Mm-hmm.
So why is it important to have a lot of tyrosines? We just said, right? Thyroid hormone is synthesized from tyrosine. So Mashoud, like when we say like T1 or T2 or T3, T4, what is the 1, 2, 3, and the 4 refer to?
That just means how many they're attached. I think it's how many atoms will be attached to that one
What
tyrosine.
atom? What specific atom?
Is it what type of atoms? Will be the non-polar atoms?
So remember, thyroid hormone is made out of two things, right? Tyrosine, which
Yeah,
is
so it's
coming-
made of tyrosine and iodine.
Perfect. Yeah.
Oh, iodine.
Yeah, exactly. So it refers to how many iodine or iodide atoms there are. Yeah, that's it. That's literally all it is. Right? So how would then, Natalie, how would you make the T3 precursor within the thyroid gland?
So I believe, are you talking about?
Generally speaking, again, now I'm reading these questions. I realize these are kind of vague, so I apologize.
So I mean, when molecules come into the thyroid gland, the tyrosine and the iodine get coupled together. And so if you're doing a T3, you have two tyrosine molecules, one with one iodine and one with two iodine.
Boom! Exactly. Wow. I'm shocked that you understood what I was trying to ask. But
I'm
that
like,
was
I
really good. Yeah, that's really good. Perfect. Thank you. Despite my best efforts, you still were able to answer that. So thank you. So yeah, you have one tyrosine that is one iodine atom, right? So that would be the T1, right? And you got one tyrosine with two iodine atoms. That's the T2, right? So one iodine plus two iodines makes 3. So that's where the 3 comes from, literally. It's a really, really basic. So Paula, building off of Natalie's mind reading, can you please tell us how you get a T4 precursor made within the thyroid?
So it's made the same way, but instead of joining one MIT and one DIT, you join 2 DITs, which come up to a total of 4 iodide atoms.
Perfect. Exactly. Wow. And you're even using like the technical terms. You guys are like, oh man, you're really throwing me a lifeline. Thank you. Yeah. So you're putting together 2 diiodinated tyrosines.
That's what they stand for. I don't remember that. Yeah, I just remember like kind of like DITs.
Yeah. Perfect. So what exactly, Perlina, is colloid? Again, another vague kind of read my mind question.
Well, it's a collection of what's in the cell, so thyroglobulin.
Yeah, it's basically just a bunch of thyroglobulin, I guess is like the best way of thinking about it, which thyroglobulin in it of itself has a thyroid hormone precursor. So this is all just to build towards this wonderful picture that I found on Wikipedia, which is great for these kinds of things. We are going to walk through exactly how thyroid hormone is made. Okay, so basic diagram, let me walk you through. So you've got your nucleus, where you get transcription of the thyroglobulin protein, which eventually is translated in the rough ER. Right? So you have the thyroglobulin, right? And as you'll see, remember, thyroglobulin is just a long protein that has a ton of tyrosines, 134 tyrosines, right? Because thyroid hormone is made of just tyrosine and iodine. That's it, pretty much. So thyroglobulin is exocytosed into, right? So we're looking at the thyroid follicle, right? So you've got the follicular cells ringing it, and then you've got this pink stuff in the middle, which is the colloid, right? So into the middle of this, outside of the cell, into the center of the follicle, you have your thyroglobulin, which undergoes a number of reactions. But essentially what you're doing, right? So you've got tyrosine here, and then you've got tyrosine here, But the difference is that now I've added iodine to it. That's what these little balls are supposed to represent. So we've got iodine that's been added here. And then you stick the tyrosines together. Right? So this would be DIT, this would be MIT, right? Because there's monoiodinated and diiodinated tyrosines. So then you stick them together, and what do you get, right? So this would have, Sebastian, would this be T1, T2, T3, or T4? This one right here.
That would be a DIT and a DIP together, so that would be a T4.
Boom, exactly. Yeah, exactly. And Sharon, what would this be? T1, T2, T3, or T4? Precursor. Technically, it's not those things yet because you have to cleave it off, but the precursor to what, Sharon? I think Sharon may not be able to respond. So this is T3, right? So 1, 2, 3. Hyperthyroid hormone is actually really simple. Again, it's just iodine and 2 tyrosine. It's pretty crazy. And so then it goes back. So then TSH, what's not pictured here is TSH then, when it stimulates the cell, it endocytoses this, and then you proteolyze, right? You cleave the thyroglobulin, and then you release the tyrosine, or the T3 and the T4. Okay, so again, let's go down the list. So to make it really clear, Alex, so what is this thing right here?
Tyrosine molecule.
Perfect. And Alex, can you tell me how many iodines are on this thing?
2.
Perfect. And Catherine, can you tell me how many iodines are on this thing?
1.
This whole thing. Remember, so now they've been conjugated together.
So that's the whole thing. So that's T3, correct?
Yeah, exactly. There's 3 iodines.
3.
Yeah, perfect. Right. So it's technically not triiodothyronine yet because you have to cleave it off. This is technically, but this would be like a T3 precursor. So yeah, again, this is not like endocrine. I love because it's pretty simple, honestly. Like it's simple and it explains a lot. Like it's one of the few things where like one theme can really apply to just about everything. So perfect. So next, let's go to Danielle. So Danielle, can you tell me again, repeat, what are the 2 major things that thyroid hormones are made from?
They're made from tyrosine and iodine.
Perfect. Tyrosine and iodine. Great. And so how exactly, Danielle, does radioactive thyroid ablation work?
I'm not sure. I'm actually not sure. I never really understood how the radioactive thyroid ablation works. Kind of just something I know.
I know. We know that we do it, but we don't know why. Can someone?
Yeah.
Can someone?
I need a
explain
lifeline.
how radioactive thyroid ablation works? It's like magic. Like, oh yeah, there's this thing, it ablates the thyroid.
Can I try this one?
Please.
I'm not positive, but
That's okay.
I think you give an iodine that is radioactive, like it's not a normal iodine molecule, and it's still going to get uptake by the thyroid. But since it is radioactive, instead of forming like T3, T4, it's going to actually cause degradation of the thyroid because it can't make any molecules out of it. So you're going to get a decrease in T3, T4 through that process.
Kind of. So you are correct that it is radioactive. You are correct that thyroid takes it up. It's not like I actually think it probably is incorporated in, right? That'd be my guess. It's just like a radioactive isotope, right? So just like hydrogen is normally 1 neutron, but sometimes it can have 2 or 3. So it's the same, or I guess proton. Sometimes it can have extra neutrons for hydrogen. So in terms of iodine, so it's radioactive, so it's taken up, and it's just radioactive, right? It is releasing radiation to the immediate environs. And so you're taking advantage of the fact that, right? Because you'll use it in things like Graves' disease or hyperthyroidism, right? Where you're making too much thyroid. And so you want to destroy these things that are overproducing thyroid. And so it's perfect, right? This is the one place that you use iodine in your body. And so you can increase the amount, or rather, if you give iodine that's normally taken up only by the thyroid, it'll be taken up by the thyroid, just like normal iodine is taken up by the thyroid. And then it will cause you to have damage to the thyroid. Perfect. So questions, does that make sense? It's a pretty brilliant mechanism, if you think about it. Just taking advantage of the normal uptake of iodine. And it's kind of like a Trojan horse, right? They gave them that like Trojan horse, and then inside of it was bunch of guys, like soldiers. It's kind of like that. It's like you are putting something that is going to be bad for the thyroid into the thyroid, and you're ensuring that it only goes to the thyroid because the thyroid is the only thing that takes up iodine. So Elaine, can you tell us what medication would you need to take if you've had a thyroid ablation?
You would have to give thyroid hormone.
Yeah, exactly. Yeah. one of my church friends actually had a thyroid ablation, radioactive thyroid ablation, and she has to take thyroid for the rest of her life. Yeah, because you've destroyed the thyroid, right? Like you did your job, but it will no longer participate in the HP, the hypothalamus pituitary thyroid axis. So what instructions, Elisa, would you have to give patients about medications or food if they're about to get radioactive ablation of the thyroid?
Okay, let me think. I think you
don't have to overthink it, right? Like what normally would, so you want to prevent, basically you want to maximize the uptake of iodine into the thyroid. How can you
Right.
do that?
So would you say by decreasing foods that normally or salts that are iodinized?
Yes, exactly.
Okay.
Yeah.
Okay.
And why?
Because they would compete with the sodium, the Na iodide transporter. It's a transporter.
Yeah, exactly. Because it's essentially, I mean, at core, there are just competitive inhibitors of each other. Right? If the normal iodine is taken up, that means that's one other molecule or one other atom of the radioactive iodine that's not going to be taken up. Right? Essentially, right? It's not perfect like 1-to-1, but you can think about it that way. So yeah, exactly. Does that make sense?
Yeah.
Yeah. So this is a big deal because it's hard because like everything contains iodine, right? So you talked about like the iodinated salts, but like everything has, like almost everything is iodine. So, right. So you're giving them radioactive iodine. If there's regular iodine around, then it will also go in through the sodium iodide symporter. And so then there will be less of the radioactive iodine that's taken up, right? Pretty simple. So instead, what you do is you tell them no iodine. And I don't know for how long, but it's for a bit. And the reason is because you essentially want to starve, because if they have less iodine, then it will increase the amount of iodine that it takes up even more, and there'll be less to compete to go in. And so if you reduce the amount of regular iodine, now there's even more radioactive iodine that will be taken up. So you'll have more radiation going to the organ that you want it to go to, and less radioactive iodine just floating around in your blood causing damage other places. So yeah. Cool? Make sense? We have a question about the difference between T3 and T4 and the role of T3 being more active while T4 is, yeah. So I don't want to go too much into this. I will say that so in general, what you need to know is that T3 is more active and that T4 is oftentimes considered like a pro-hormone. I don't know that there's much more that you really need to know for like these exams. Is there something specific, Jason, that you were wondering?
Nothing specific in regards to that. And I guess from first and second year was kind of drilled in our head, like, oh, T3 is an active one. T4, there's more of it. And just trying to differentiate or just learning what's really, I don't want to be very general, but the big deal between the two, aside from that, is kind of what I was trying to drill down a little bit more on, because that's like basically.
So when you get to like the nitty gritty, so my mom is hyperthyroidism. I don't think she would mind me saying this. So my mom is hyperthyroidism. What's interesting is that like, this is something you didn't know in medical school, but like she basically has to take T3 and can't take T4, because normally when you give someone thyroid medications, you have to give them T4, or like that's like the standard is to give them T4, the thyroxine, right, as opposed to triiodothyronine. So for some reason, some people, and this is I guess established in at least a small amount of the literature, that like because it gets more complicated, but like the conversion of T4 to T3 happens oftentimes peripherally, right? So not in the thyroid.
Okay.
And so apparently there are different conditions, or some people just don't convert it as effectively or whatever, but there's a subset of the population who do not effectively convert T4 to T3. And so it becomes relevant because like for some people, they will still have signs of hypothyroidism, even though they would have what seem to be normal levels of T4. So,
okay. All right. That makes sense then. Okay.
But like in terms of, that's like, I didn't even learn that in med school. I just did extra reading because my mom was like telling me about like, I need T3, and I was thinking like, oh, is this real? Or is this like one of those things where, patients tell me I need like brand name medications only? Like, is this just like one of those things in your head? But no, there's like actual literature behind this. So I don't want to poo-poo.
Okay,
so
so basically don't read too much into it, then just kind of know T3 versus T4 and kind of leave it at that just for board wise.
For boards, T3 is the active one. I'd say
Oh,
that's
yeah.
like what you need to know. Yeah. If you wanna like make
Okay.
people like my mom really happy, then you would understand that there's a little bit more than what's taught in medical school in that not everyone can convert T4 to T3 effectively.
Okay, yeah, I think maybe in my physiology class, there might have been some talk about that, and I just have foggy memory on it, so I just knew there was something there.
Yeah, that's
Okay, thank
most
you.
minds. Yeah, of course. All right. So next, other questions before we move on to talk about thyroiditis and the difference between hyperthyroidism and thyrotoxicosis. So let's go to Luis next. So Luis, can you tell me what exactly is the difference between hyperthyroidism and thyrotoxicosis? A common misconception in medicine.
Okay, so hyperthyroidism is basically high thyroid hormone level, in this case T3 and T4, because of an overproduction of those two hormones. Overproduction.
Good. How about thyrotoxicosis?
It's also high levels of thyroid hormones, but I think it's okay. It's high thyroid hormone levels, but it may compromise your life, or there's an evidence, kind of like a storm, or it's too much thyroid hormone that can lead to a.
So it's actually, so interestingly enough, so the difference is, so you were right about the hyperthyroidism. So hyperthyroidism means you have high thyroid hormone levels because you're overproducing it. Thyrotoxicosis doesn't mean that it's like, it sounds like, oh my God, I'm gonna die, like thyroid storm, something crazy like that, but it's actually not. Thyrotoxicosis just means I have high thyroid hormone levels just for any reason, right? So in other words, hyperthyroidism is a type of thyrotoxicosis. Right? It's a specific type of thyrotoxicosis, right? So if I took high, like exogenous thyroid levels, I would be thyrotoxic, but I wouldn't be hyperthyroid. I'm impressed that you knew that hyperthyroidism was because of overproduction. There was a senior, when I was a first year medical student at Stanford, there was a senior lecturer who like swore up and down that hyperthyroidism just meant that there was higher thyroid like hormone levels. And I was like, well, okay, so then what does thyrotoxicosis mean? He had like nothing to say, because yeah, this is a very misunderstood concept. So, but very simple. Hyperthyroidism means high thyroid hormone levels because you're making too much. Thyrotoxicosis means I just have high thyroid hormone levels. It's a variety of causes. So, Maliha, what would be an example of hyperthyroidism?
Graves' disease.
Oh, yeah, perfect. And how about Manny? What would be an example of thyrotoxicosis?
That would be taking like exogenous thyroid hormone.
Perfect. Can you give me another example?
Sorry, I'm not sure.
Okay, that's okay. So another example would be, so taking too much thyroid hormone, certainly. Another would actually be thyroiditis. So inflammation of the thyroid gland.
How does that work?
Ooh, I'm so glad you asked, because that's going to be our next slide. So remind me, Marco, what exactly is thyroid colloid?
Thyroid colloid. It's a collection of thyroglobulins.
Yeah, it's just a bunch of thyroid globulin, which has the thyroid hormone precursors, right? So, Marco, can you tell me, like, how could thyroiditis lead to thyrotoxicosis? How does that make sense?
Oh, it's an inflammation of the thyroid. So if the inflammation leads to great storation of thyroid hormone on the gland.
Yeah, exactly. Yeah, essentially. So the idea, right? So unlike other organs, the thyroid gland stores a ton of thyroid hormone, right? I mean, like other organs have like a little bit in vesicles, but like the thyroid hormone, like it stockpiles thyroid hormone in the form of the thyroid globulin that makes up the colloid, right? And so when you get inflammation, I don't know why. I assume it's because of, because like you have proteases in neutrophils and macrophages and stuff, right? So I presume that some of those proteases can cleave T3 and T4 and release it, but that's like a hand-wavy explanation. But the idea is that you have inflammation of the thyroid, and you can see actually that the colloid just like disappears. And the idea is that you're basically just depleting the colloid because you're cleaving it and you're releasing all that stored thyroid hormone into the bloodstream. That leads to thyrotoxicosis.
Okay. Cool.
Manny, does that make sense?
Yeah.
Yes, it does. Yes.
So Mashoud, what would the TRH, TSH, and T3-4 levels be in someone who had thyroiditis? And early thyroiditis, and why?
Okay, so in early thyroiditis, I'm thinking, okay, so because you said the thyroid has a lot of thyroid hormones, it's inflamed, so that means there's a lot of release of the hormones. And then so if I'm releasing a lot of thyroid hormones, I'm releasing a lot of T3 and T4.
Perfect.
And then I believe, and then going back to the hypothalamus pituitary axis, if I have a lot of T3, T4 due to negative inhibition, I believe that will decrease TSH and TR.
Yeah, exactly. Perfect. Yeah. Again, it all just comes back to feedback inhibition, right? Like as long as you understand the HP, end organ axis, and the hormone decreases activity of the H and the P, in other words, the hypothalamus and the anterior pituitary, everything just makes sense. So yeah. So your T3 and your T4 would be high. You have inflammation, release of T3 and D4. That is going to feedback inhibit the hypothalamus and the pituitary. Boom. Yeah, exactly. So Natalie, in someone with late thyroiditis, what would the TRH, TSH, and T3, T4 levels be, and why?
I would think that in early thyroiditis, you kind of release all of your T3, T4. Maybe in late thyroiditis, you wouldn't have as much stored up, so then that would decrease. And then that decrease would lead to, you wouldn't have that feedback inhibition on TRH and TSH. So then those two levels would be high.
Boom. Nice. You're ready.
I hope so.
Yeah, that was good. That was really good. Yeah, exactly. Again, this is the kind of rationale that you need to be able to do on the spot on your test. That's it. That's all they're asking you to do, is to reason through it, to use your knowledge to reason through a situation that maybe you haven't seen before. That's it. That's all they want. They want you to be able to use it. They don't want you to memorize it. So good. That's good. So yeah, the problem is that you've released all of the T3 and the T4, and it's been degraded in your body like all hormones eventually do. But because the thyroid has had too low of TRH and TSH for too long, you haven't replaced it. You don't have it. And so now you have too little thyroid hormone, which causes disinhibition of TRH and TSH, which causes an increase in TRH and TSH. So in early thyroid toxicosis, the problem is that we have an increase, right? We have a release of all that colloid, all that stored T3 and T4. That's going to cause increase in inhibition of the hypothalamus and the anterior pituitary, which is going to cause a decrease in my TRH and my TSH. Perfect. And we can probably end on this. So Paula, how exactly does radioactive iodine uptake work? And how is it used specifically for the diagnosis of thyroid pathology?
What was the first part?
How do you use radioactive iodine uptake to diagnose thyroid pathology?
So I think from what I remember that when you want to see that the thyroid does take up the iodine, and so you can visualize that through giving the person radioactive iodine and visualizing it through some kind of machine that detects that. And so if the thyroid gland isn't working, it won't uptake the iodine you gave the person, and you would see it you wouldn't see it in the imaging system you're using. Is that right?
Yeah, essentially. If the thyroid gland isn't working is a little vague. I guess I would say specifically, if you're not actively making thyroid hormone, then you wouldn't take up the radioactive iodine. But yeah, otherwise that's exactly it. So you give radioactive iodine, right? So it's like in the case of radioactive thyroid ablation, right? It's radioactive iodine, but in this case it's different in the sense that it's the radiation that it emits is not like really toxic like the other kind of radiation. They do that by just having a different isotope that they give. And so it goes to the thyroid gland, and if the thyroid gland is making thyroid hormone, it'll take it up. If it's taken up, then it'll decay, and then you can use a nuclear medicine scanner to see how much and where the iodine was taken up. It's pretty cool, right? So let's look at what this would look like. So I got this image plus paper, which was referenced actually in Wikipedia, which is, again, a great place for finding a lot of these things. And so what you do is so you've given someone radioactive iodine. It goes to their body, again, because the thyroid is the only place that's going to use that iodine. If the thyroid is making thyroid hormone, it'll look like this, right? So all of the cells have taken up that iodide. And so the iodide is sitting in those cells, and now it decays. And as it decays, right, you can use essentially like a Geiger counter to look at where the decay is coming from and how much there is. Okay. So normal would be A. B would be this would be like Graves' disease, right? So you can see how there's more of all of this everywhere, right? So this would be like Graves' disease. C would be, do you know what C would be?
Oh, sorry.
This is a hard one.
Is it like thyroiditis?
No. So thyroiditis would be like, we'll talk about that. Thyroiditis would be E.
Okay.
But C would be like a toxic multinodular goiter, right? There's many nodes that are overproducing thyroid, right? But if you think about feedback inhibition, right? So you're making a ton of thyroid in these nodes. You'll notice that the other parts of the thyroid that aren't dark, they are actually lighter than normal. And that's because so these are independently producing, so also known as hot nodules, right? These are overproducing thyroid hormone, which is going to feedback inhibit TSH and TRH, which is going to cause for any cell that will still respond to TSH and TRH, meaning basically any normal thyroid cell, you'll have a decrease in production. So that's why it's actually darker in the other areas, which is also what you see in D, right? So D is just one big hot nodule. This would be like I think it's like an adenoma, like a thyroid adenoma. It's just a nodule that's producing too much thyroid hormone. And so again, you'll see that there's little production everywhere else. E is thyroiditis. Can someone explain why E would be thyroiditis? Or Perlina, if you want to give it a shot. So
Well, you're making less thyroid hormones.
Why?
So it's not going to be as dark.
Yeah.
Because so you're making less in thyroiditis, you're making less thyroid hormones. So then you won't take in as much of the radioactive iodine.
Yeah, exactly. And why are you making less thyroid hormone?
Because it's thyroiditis, because it's inflamed. So you release more and then it'll die down.
Yeah. So walk me through again. I want you to use the concept of feedback inhibition. That is if there's like one thing that you learned from today, it would be feedback inhibition. That's like the key concept in all of endocrinology.
Okay. So with thyroiditis, you're initially releasing more thyroid hormone, which is inhibiting the TSH and the TRH. So those would be low. And then as time goes on, you're not making more of the thyroid hormone. So the levels would decrease, which would stop the inhibition of the pituitary and the hypothalamus. So your TSH and TRH would increase.
Yeah.
To try and make more.
Eventually. Yeah. But in this case, this would be like early thyroiditis, right? So what he's describing in the beginning, where you have release of the T3 and the T4, which will cause, like you said, a decrease in TSH and TRH release, which means that you will be making less thyroid hormone. And again, thyroid hormone is just tyrosine and iodine, right? So if you have less TSH, you're going to be taking up less iodine. So you're going to need to make less thyroid hormone. So yeah, so that's why you don't see it really dark. It's minimally dark. You can kind of barely see the hazy sort of outlines. Yeah, exactly. Well done.
Thank you.
So Sebastian, tell me, we kind of already talked about this, but use the underlying pathophysiology to explain how the labs would look in the early part of the disease for Graves versus subacute granulomatous thyroiditis.
Okay, by limiting. So I think in both the T3 and T4 will be high, meaning that if we measure the TSH and TRH, they will be low.
Good. Yeah, exactly. So how would you know? How could you tell the difference, right? Or similarly, right? What if someone was taking like exogenous thyroid hormone? How could you tell the difference?
By doing a radioactive iodine.
Ooh, interesting. And what would that tell you? How would you be able to tell by using radioactive iodine?
Well, it's great disease. Okay, if you're taking exogenous thyroid hormone, your thyroid is not making the thyroid hormone, meaning that there will be less uptake of iodine, so less reactors and less painted in the nuclear scanner, right?
Perfect. Yeah, exactly. How about Graves?
In Graves, there's an autoimmune disorder telling your thyroid to make more T3 and T4, meaning that the uptake will be higher. So there will be more activity in the thyroid gland.
Perfect. Yes, exactly. Perfect. Yeah. So this is, again, a very important concept to know. They love to test this on step 1, right? So the early labs would be identical. TSH would be low, TRH would be low, your free T3 and your T4 would be high. However, right, because you have the thyroid stimulating immunoglobulin, right, the antibody against TSH in thyroid disease, in Graves' disease, you're making more thyroid hormone. So you would have more radioactive iodine uptake. It'd be high, right? Right. You can see here, right? So it's high. You're making more. Whereas in the case of thyroiditis, you're making less thyroid hormone, right? Because in this case, there's low TSH, and you don't have something that's telling your thyroid to make more, like an antibody against TSH, the TSH receptor. So your radioactive iodine uptake would be low. Yeah, exactly. So That's why thyroid, so even though the labs would be the same, right? High T3, T4, low TRH, low TSH, between Graves, B, and thyroiditis. In the case of Graves, it's because you're actually hyperthyroid. You're making too much, right? So you would have a high uptake. And in E, you're not making any. You're making much less. And so you'd have low radioactive uptake. This is a very important concept for your test. All right, perfect. So I am going to end this here. Questions, comments, concerns before we wrap up. We'll do more next time.
Alec, I just have a quick question. You said in Graves' disease, TSH would be low. Is it explain really quick? Because I'm thinking, I don't know if I'm thinking wrong or something, but if you have TSI, wouldn't is that stimulating TSH directly or?
No, it's a receptor. Okay. It's basically as if the receptor it thinks that there's high TSH, right? Because you have an antibody it's a weird antibody, right? Like normally you think of antibodies as causing a dysfunction. In other words, it causes it would block the receptor so that it doesn't work. In Graves' disease, the antibody actually causes the receptor to work, right? So so your body thinks that TSH is high because you have these antibodies binding to the TSH receptor, but your TSH is actually low, right? Because you have feedback inhibition from the high T3 and T4 that you're making.
Oh, okay.
Does that make sense?
Because I thought TSI directly stimulated TSH.
Yeah, no. At least I'm pretty sure, unless someone corrects me. I'm pretty sure that TSI is against the TSH receptor specifically. And so if it's against on the thyroid gland, so it stimulates the thyroid gland, it's basically like an independent mechanism of stimulating the thyroid gland. That's not TSH. And so you overproduce T3 and T4, and the overproduction of T3 and T4 will cause a decrease in TSH and TRH. Natalie says that's correct, and she's taking her sub-1 in a week and a half, so it's got to be correct.
Right. All right. Thank you so much.
Yeah, of course. Other questions?
Yeah, Alec, really quick.
Yeah.
So thyroiditis can be found so there's some inflammation, meaning that the follicular cells will be separating. So the content in the colloid would leak out, so meaning that more T3, T4 is at the bloodstream.
I guess so. I don't know exactly why it does. I know that it does. I would maybe it's like you said, it would make sense that it was like leakage out, like you get edema into cells, like leakage of the colloid in between the cells. Certainly plausible. I don't actually know if that's true. But if you look at look at a picture of Hashimoto's or thyroiditis sometime, look at histology pictures, you will see that the colloid, right, instead of being this plump pink thing, it looks like raggedy and it's all gone.
Okay.
So I don't know. The way that I make sense of it is that so you think about emphysema. Right? Emphysema is driven by inflammation. So you have neutrophils that go to the alveoli and they release proteases, right, which break down protein. And so they break down the elastin and stuff like that, like proteases, elastase. So the same thing is true for inflammation of the thyroid, presumably. So you could have, inflammatory cells, which I guess I presume would release proteases, and those proteases could cleave, again, the protein, thyroglobulin, which would release T3 and T4. That's a hypothesis. I don't know if that's true. What I do know though is that you have less thyroid colloid, and yeah, it happens presumably because of inflammation.
Okay, thank you.
Yeah. Other questions? These are good questions. Great questions. Marco.
I have one, please. There's a situation that is called subclinic hypothyroidism.
Oh, yeah.
Yeah. It's a tough thing. I don't know if it's really asked on the step.
Not step
situation.
1. Sometimes maybe step 2.
Yeah.
To be honest, I don't really
think about that.
Subclinical. Yeah. Let me look that up and I'll give you a better answer next time. It never really made sense to me, honestly. If you have the answer, please tell me. But I don't want to. I want to give me I will look it up. But give me a chance to give you a better answer. I don't want to lead you down.
Yeah, I'm asking you that, but just afternoon I have seen a patient that she has a diagnosis of hypothyroidism because of Hashimoto's disease, but she's taking the thyroid hormones, the T3, the T4, but he still has a few symptoms like fatigue, like edema at the lower limbs, but she has good results on
all of her lab tests.
Okay, so she's taking the medication. She has a good results on the lab, but she still has some symptoms. That's our lesson today. We recalled her this afternoon.
I don't know. Yeah, I don't know. I mean, I'm by no means like an endocrinologist, but I don't know. I mean, is she taking T3 and T4 or just T4?
No, just T4. Just T4.
So it could be like my mom. I don't know. It could be like my mom. She may, because again, the problem is that we measure T4, right? Usually we measure free T4, even though T3 is the active one. So it's theoretically possible that maybe, I don't know. Let me look up subacute or subclinical hyperthyroidism more.
Okay.
But I guess one thought would be maybe it's that you can't just give T4 to people that are hyperthyroid.
Okay.
So that's a possibility.
Mm-hmm.
Good question. Other questions, thoughts, concerns? So I know that we've gone over this now 2 times, but I want to do it, or 1 time, but I want to do it again just because it's really important for what we're going to talk about. So I'll probably include this in the Google Doc so that you guys can see it, but I'm just going to have this here so you see again, LFTs, not tests of liver synthetic function, even though they're called liver function tests. So bilirubin, as a reminder, is a breakdown product of heme. Direct is conjugated, indirect is unconjugated, right? It explains a lot of the things like the color of poop and pee, also the color of bruises and other things. AST and ALT are basically, they're enzymes found within hepatocytes that are only released or mainly released if you have hepatocyte damage or death. So that's the main reason why AST and ALT are elevated. Alk-Phos is the main reason is actually because of an increase in synthesis, right? So this will become really important because we're going to talk about all of the LFTs and the patterns today. And because you'd think that if it was just because of leakage from damaged cells, that AST, ALT, and Alk-Phos would all be up in the equal amounts, but they're not. And it's because they're elevations for different reasons. AST and ALT are mainly because of damage. Alk-Phos is mainly seen in biliary stasis because of an increase in synthesis. Right? Obviously, AST, ALT, and Alk-Phos are found in other things that are not just hepatocytes. Alk-Phos is the one that you really should know about, although AST is also found in like muscle and stuff like that. But Alk-Phos is found in bone, liver, and placenta, among other things. And as a reminder, for acute liver failure, the most common ways of measuring synthetic function, there's a couple others other than PT and albumin, but the most common ones are PT and albumin. So acute liver failure, PT's up, albumin's normal, and then chronic liver failure, PT's up and albumin's low. That has to do with half-lives. So with that in mind, I want to go to our question. So a 25-year-old male has a 1-week history of fatigue and nausea with a 2-day history of skin yellowing. His past medical history is unremarkable. He denies any alcohol, tobacco, or illicit drug use. He works in a local restaurant. His temperature is 37.8, heart rate is 90, blood pressure is 115/78. Physical exam is significant for jaundice. His liver is slightly enlarged without tenderness. Abdominal exam demonstrates no spider angioma or fluid wave. What is the pathophysiologic chronology? So his labs, you can see, are bilirubin total is 6.2, direct bilirubin is 3.8, Alk-Phos is 200, AST is 1221, alanine aminotransfer, so ALT is 1349. PT and albumin are normal, and he's got positive anti-hepatitis A virus IgM, negative HIV IgG, and he's got anti-HBs antibody, which is positive, and then anti-hepatitis B core antibody, which is negative, and negative hepatitis B surface antigen. So I want you to walk through the pathophysiologic chronology. So let's go through the pathophysiologic chronology. So the summary would just be that he's got, from fecal-oral transmission, he's got an acute hepatitis A infection that leads to, we'll talk about the different patterns, but a very clear hepatocellular LFT pattern, sometimes called intrahepatic. So that's why because it's an acute infection, that's why it's IgM and not IgG. He's got inflammation of the liver, which we'll learn anytime you have inflammation of the liver or basically the gut tube or any of the derivatives, so liver, gallbladder, appendix, or pancreas, you can get nausea. It's possible to get nausea. And so we'll talk about the detail later, but that's the big picture sort of summary of what's going on. So our summary of key concepts. So the main thing that we're going to go through today is to talk about the different patterns that you see for LFT abnormalities, because this comes up a lot. And so there is a more intuitive way of thinking about it, which is to think about it very similarly to how you think about like kidney failure. So you can think of it just like there's pre-renal, intrarenal, and post-renal. There's also, you can think about it for jaundice especially, you can think about it in terms of prehepatic, intrahepatic, and posthepatic. It doesn't work quite as well as it does with the kidneys, but it works like 90% of the time, which is pretty useful. It's a pretty intuitive way of thinking about it. I am going to include, however, the more common way of describing LFT abnormalities, which you'll see more in textbooks. And certainly that was what we learned at Stanford and what they did at MGH, which is thinking about it in terms of just recognizing the pattern. So isolated hyperbilirubinemia, which is kind of like the prehepatic, hepatocellular, which is essentially like the intrahepatic, and then cholestasis or cholestatic, which is basically your posthepatic. So there's a lot of overlap between them, which is why I included them in one. Sometimes you'll also see infiltrative, which I didn't include, but that's basically where you see just an increase in alk-phos and none of the others. So the other thing I want to talk about is a way of thinking, a systematic way of thinking about nausea and vomiting that is, I think, really helpful. Because when I was at your stage, it was really hard for me to think about nausea and vomiting because I was like, I don't know, like, can esophagitis give you nausea? What does that tell us? What does it mean? So the punchline is going to be that anytime you have obstruction or anytime you have inflammation of a gut tube or one of the 4 buds, so the pancreas, liver, appendix, or gallbladder, it can, not always, it can lead to nausea and or vomiting. Obvious caveats are that not all causes of nausea and vomiting are GI related. Right? You can obviously get GI. There are lots of causes of nausea and vomiting, which we're not going to talk about today. We're just going to focus on the GI causes. But it's useful to know what are the things that can cause nausea and vomiting from the GI. It's also important to note that the lack of nausea and vomiting does not rule out GI causes. Right? So if you don't have nausea, it doesn't mean you can rule out like hepatitis. That said, it is still a really useful way of thinking about nausea and vomiting. It's also really useful because you can use this as an analogy to think about coughing. Because again, I always had a really hard time of thinking like, what would cause coughing? What's a good systematic way of thinking about coughing? And so in the same way that obstruction or ultimately pressure or inflammation of the gut tube or its derivatives can cause nausea and vomiting, basically the same thing in the respiratory tract can cause coughing, right? If you increase pressure on the wall of the respiratory tract, so a bronchoscope, something where you're looking into someone's lungs and you brush the side of the wall, they will cough like crazy. I can tell you that. Personal experience. And inflammation, also the same thing, right? Like, why do viral illnesses cause so much coughing? Asthma. Why do steroids help with reducing coughing, right? It's basically the same idea. All right. And with that, we will get started. All right. So our systematic approach. So as a reminder, there are 2 most common causes of approaches for LFT abnormalities and for jaundice. So again, the most common is to look at just the pattern recognition. So you'll see hepatocellular, isolated hyperbilirubinemia, cholestatic, and then sometimes invasive. It's essentially high alk-phos, but everything else is close to normal, including the bilirubin. So it's sometimes included, so I describe it just so that you know, but it's not that common. So bilirubin, the more intuitive way of thinking about it is to look at causes of jaundice. So causes of jaundice, one schema is to say prehepatic, intrahepatic, or posthepatic. So they're essentially interchangeable. And so in the hospital, you'll probably hear this more often, but in your head, oftentimes I think it's actually more useful to think about in terms of pre and post. But I included both so that you can rock both the intuition as well as frowns. So let's go to Paula. So Paula, prehepatic versus intrahepatic versus posthepatic. So using your knowledge of bilirubin, explain which would have the highest direct conjugated bilirubin and which would have the least, if it was pre, intra, or post.
The highest conjugated posthepatic.
Perfect. Yeah, exactly. And why does that make sense?
Because when we're talking about posthepatic, we are saying cholestatic. So then if we have a problem, if the problem is not in the liver, so we're going to be able to conjugate the bilirubin. So from indirect to direct.
Exactly. Yeah. Great. So posthepatic is going to have the most. Sorry, I shouldn't show it to you. So which is going to have the least?
Then it's going to be the prehepatic.
Good.
Yeah.
Yeah. So post, right? Because the liver is fine in posthepatic, right? So you can conjugate just fine. The problem is that the conjugated bilirubin, for whatever reason, cannot make it into your GI tract. So there's cholestasis, right? So that would have the highest conjugated bilirubin. Intrahepatic is going to be in the middle. So you're in the process of conjugating it. So you're conjugating some of it, but because of damage to the liver cells themselves, you're going to have spillage of bilirubin from inside the hepatocytes. The prehepatic, there's the least direct bilirubin. You are increasing the production of unconjugated bilirubin in most of these cases. The other cases of isolated hyperbilirubinemia would be like what we saw before with Gilbert, where the problem is that you just can't conjugate it. This is why it's not quite as perfect of a schema as it is to say pre-renal, intrarenal, post-renal, because it gets a little messy to say like prehepatic for things where it's a problem with conjugation. It's a problem with the liver, but it looks like the prehepatic. So that's why I think it's probably not quite as common, because it will not cover 100% of the situations. It is more intuitive though, which is why I included it. So pre-hepatic versus intrahepatic versus post-hepatic jaundice. So using your knowledge of bilirubin, explain which would have the darkest urine and which would be the least dark. All right, we'll move to Matan. So Matan, what do you think?
So we look at the solubility or the polarity of the molecules. So direct bilirubin is polar, therefore it's not bound to albumin, it's freely filtered, it'll end up in urine, urine will be dark. Unconjugated or indirect is non-polar, it's bound to albumin, not freely filtered, it won't darken the urine.
Boom. Yeah, exactly. So in other words, the post-hepatic is going to have the darkest urine. Absolutely. And it's for exactly the reasons that you said, because the direct bilirubin will be soluble in the water, and so it can actually enter the urine. And so that's why post-hepatic is going to have the darkest urine. Intrahepatic, again, is going to have the middle. It's sort of like Goldilocks. It's going to have the middle amount of conjugated bilirubin, so it's going to have maybe a little bit of dark urine, but not too much. And then the prehepatic is going to be mainly unconjugated bilirubin. So less than 20% of it's going to be conjugated. And so that is going to be largely not dark urine. It is almost never dark. Great, or at least from the bilirubin itself. All right, so Joni, so using your knowledge of AST and ALT, which would have the highest levels?
So AST and ALT are indicative of intrahepatic. Would it be?
Yeah, great. Yeah, so the highest in intrahepatic. Great. And why?
It's AST and ALT are indicators of hepatic hepatocellular damage.
Yeah, they're enzymes that are found within hepatocytes. If you have damage to the hepatocytes, they'll be high. Great. And so great. Exactly. So post-hepatic might have a mild elevation, right? Oftentimes a little bit, which is why I think people get confused, because there will still be some elevation even in post-hepatic, presumably because you still get some damage from cholestasis if you get backup of bile, although it's not nearly as much as it is in intrahepatic. So prehepatic has virtually no elevation. So the reason why it's called isolated hyperbilirubinemia is because that's basically all you see. All you see is the increase in bilirubin that is indirect. All right, Grace. So using your knowledge of ALK-Phos, which would have the highest levels?
So would you say, would it be post-hepatic?
Yeah.
See, I know that increased ALP is associated with cholestasis. I'm trying to remember.
Yeah, it's not super important to remember why. There is an increase in synthesis, right?
Right.
So the reason is because of an increase in synthesis. The reason why I include that, as opposed to just memorizing this, because it helps explain why because it is actually an enzyme that is found within hepatocytes. So you would think that if you damage hepatocytes directly, that ALK-Phos should increase the same amount as AST and ALT. But the reason why it's not is because the major reason why ALK-Phos goes up is because of an increase in making of ALK-Phos. And that happens for whatever reasons that are unclear to me, when you have cholestasis. So it's interesting. It's not, at least in the papers that I read, we don't know what ALK-Phos does in what the major purpose is in the GI tract. So there is a small elevation, right? So it's the opposite of the AST and ALT, right? So for hepatocellular, you have a lot of AST and ALT and a little bit of ALK-Phos. For the post-hepatic or cholestasis, you'll have a lot of ALK-Phos and a little bit of AST. A lot of ALK-Phos, a little bit of AST, ALT. So prehepatic, again, it's isolated hyperbilirubinemia. You don't really see much of any of the ALK-Phos. So sometimes you will see something called R factor. So let me tell you what R factor is. I don't think that it's one of those things that you should memorize. I think the concept is more valuable. So I want to talk about this. It was actually in the white book for MGH for like the interns that talk about like LFT abnormality. So it is used sometimes, but I think the concept is probably more valuable because I think people still get really confused about like how to recognize these patterns. So R factor in the equation is ALT over ULN, which is the upper limit of normal. Sometimes you'll see ULN. So ALT over the upper limit of normal divided by ALK-Phos over the upper limit of normal of ALK-Phos. So the major downside to this, because you may be wondering, because you'll see ULN sometimes, like for example, in like Light's criteria or the Light criteria, you'll see upper limit of normal for looking at total protein albumin. And so you might wonder why is this not a fixed number? It's because the upper limit of normal varies by the hospital. So I looked up what the upper limit of normal was for the USMLEs. So for ALK-Phos, it's 70, and for ALT, it's 20. So if you do the math, right, if you flip this around, right, so the upper limit of normal, right, so you're dividing by something you're dividing by. So if you flip this, right, the upper limit of normal of ALK-Phos and do the math, right? So the upper limit of normal of ALK-Phos ends up on top and the upper limit of normal of ALT ends up on the bottom. And so if you look at the ratio of these, it ends up being 3.5. For the USMLEs, again, for your particular hospital, it will be different, but for the USMLEs, I did the math and it's 3.5. So what would be then if you followed this, and then I don't think I did a very good job of explaining this, so probably couldn't follow this, but we'll see. Sujith, what would be a quick and dirty way to calculate the R factor? Right? So ALT over the upper limit of normal divided by alk-phos over the upper limit of normal. So what would be a quick and dirty way to calculate it? And what does it tell you?
ALT by ALP.
So it would be, so R factor is ALT divided by ALP times 3.5. So in other words, all of this times 3.5. Right? So this is written with the correct order of operations, but I just want to make this really clear. So in other words, if R is above 5, that tells you that it's hepatocellular. If R is less than 2, that tells you that it's cholestatic. And so again, this quick and dirty way really is only like USMLE specific. It will vary depending on the hospital. I have some examples of this. So I want to show you how you can use this and why it's valuable. The reason why I am even bringing up R factor in the first place is because just to say, because you'll see tables like this where it's, oh, what's most prominent? So AST is most prominent in the intrahepatic. Alk-phos is most prominent in posthepatic. If that's with you, you don't really have to worry about R factor. It's more when they're both elevated and you're like, gosh, I don't know. What's more elevated than normal? Geez, I don't know which is most prominent. That's where R factor comes in. And also to tell you what's mixed, because if it's between 2 and 5, that tells you that it's a mixed pattern. So Sujith, let's say that the ALT was 900 and the alk-phos was about 300. What kind of LFT pattern would this be and why? Those were the only two things you knew. Could you calculate the R factor and tell me what the LFT pattern would be?
It will be, are you asking if it's hepatocellular or pre-hepatic? This is hepatocellular.
Great. And how did you come to that?
It's more than 3.5. So 3 into 3.5 is around 10.
Great. Yeah, perfect. Exactly. So you can do it one of two ways, right? You could do it like Sujith did, where you like eyeball the R factor and see is it 5 or less than 2. That was the point of this question. But if you are comfortable just saying, well, ALT is like really high, alk-phos is just like a little high, that's also okay. Honestly, that's how normally I go about this. It's just that that's a lot harder to communicate to someone else. It's a lot harder to teach someone. Say, oh yeah, just like eyeball it and say, oh yeah, alk-phos is a lot higher than normal, or ALT is a lot higher than normal, and alk-phos is just a little bit higher than normal. That I think is harder to do, especially if you don't have a lot of experience looking at LFTs. So if you're not comfortable with that way, then R factor is for you. So you can think about it as the elevation of the ALT is much more prominent, but to be more precise, you can do what Sujith did, which is to say ALT over alk-phos is about 3, right? And so 3 times 3.5. So this is USMLE specific, 3.5. So 10, so that's a lot more than 5. So this would be hepatocellular. Cool. All right. So we are going to practice this more. Do you want to take a shot? Oopsies. Want to take a shot at this? So what pattern of LFT abnormalities is this? And what condition is most likely?
Would we first look at, I guess, the ALT? So that is going to be 1349. And then I guess that would be high. And so with the ALP at 200, so let me do that real quick. And then multiply that by 3.5, right? So 23, which is greater than 5. And so that would signal me towards an intrahepatic.
Perfect. Yeah,
Okay.
exactly. Yeah.
Cool.
So I think that's the easiest. So again, so the other way of doing it would be to say what?
The other way would just be like looking at ALT is much, much higher than ALP.
Yeah, or just to say, yeah, exactly. Or just elevated over normal is much higher than the amount that alk-phos is elevated over.
What was the normal value again for the two?
I think 70 is alk-phos. Upper limit is so alk-phos. The thing to remember is alk-phos is a bit higher than ALT. So I think it's 70 for alk-phos and then 20 for the USMLEs for.
Okay, yeah. That's a part that I wasn't familiar with. But yeah, that calculation is actually like much more straightforward for me. So that's cool.
Good. Again, I include both just to give you guys like a sense. I should be completely upfront with you. I don't use R factor. I just eyeball it and say, man, this is a lot higher than this is like real high. This is a little high.
Right. Having that frame of reference for sure. But having the equation to calculate it out for me like that, it was a lot easier.
And I figured, it was good. In fairness,
Cool.
The other thing is that you can also use the percentage of the bilirubin, right? So the direct bilirubin is a little less than 50%. So that's also very characteristic of an intrahepatic or hepatocellular pattern.
For sure.
Cool. So I included all of these so that you can be really clear. And again, let's be honest. It's patients, the real world, even the tests, they're not going to have necessarily read these textbooks. Like sometimes maybe the direct bilirubin is going to be more than 50%, a little bit more than 50%, or that's like the major one. Sometimes like this doesn't fit quite as perfectly as you want it to, but go with the thing where most of it's going to make sense.
Right. I think honestly, like when doing like practice questions and using this approach, it'll help the application part of it be a lot easier.
I think so. And so again, this is why the IgM is positive, but there's no IgG because it's an acute infection. All right, so Saba, how about this? So walk us through. So again, I want you to use as many of the different, because we want to practice this. For these purposes, I want you to use as many of the different ways of determining what LFT patterns it is. Yeah, so go for it. I've only given you one, I guess. Saba, are you there? You have to remember to unmute yourself.
Oh, sorry. Yes. So in this case, because the indirect bilirubin, which I calculated from total bilirubin minus direct bilirubin, that would be 5. Because the unconjugated bilirubin is higher, that would make me think that it's a prehepatic.
Perfect.
Because, yeah, if you haven't made it to the liver to get conjugated yet, then, yeah, you wouldn't expect.
Now look at the other labs, because again, I gave you a ton of clues here that they weren't AST, ALT, ALK-Phos, but I gave you a ton of clues. So why is there an isolated hyperbilirubinemia in this case? I'm looking specifically at the hemoglobin and the direct Coombs test. You may not have been here last week.
No, I wasn't, unfortunately.
Okay, that's okay. So I'll pick on someone else. Zach, you're taking your test real soon, so let me hear it.
All right, so direct Coombs test. So you have second autoimmune reaction. You have antibodies against RBCs. They break down the RBCs. They break down the RBCs. And in intravascular, like hemolytic anemias, your indirect bilirubin is going to be high, and your hemoglobin is obviously going to be low. So you're shredding RBCs.
So interestingly enough, intrahepatic, actually extrahepatic is more associated with high bilirubin.
Did I say intrahepatic? I meant to say intravascular. My bad.
And that's because, and let's be clear. So the reason is because if you have intravascular hemolysis, if you have shearing from DIC or HUS or something like that.
Oh, okay, yeah.
You don't have, the hemoglobin is free floating.
Yeah,
it hasn't had time, the macrophages haven't had time to just consume it, turn it into bilirubin.
Yeah. So should I rephrase this as like when you have an autoimmune hemolytic anemia, then your indirect bilirubin is going to be high?
Yes. Yeah, exactly. Yeah. Perfect. Because what question are you answering? What is that?
So like why is,
What question exactly are you answering with the direct Coombs test?
So you're answering, do you have antibodies against the RBCs? Is that what you mean?
Yeah.
Or antibodies against
the question is, did immune-mediated hemolysis happen already?
Okay, yeah.
Versus the indirect is basically saying, could you have
potentially have it if you added RBCs?
Like, do you have antibodies that could cause?
Yeah, this is like what we did last week.
Yeah, exactly. Perfect. Yeah, exactly. So that's why. So in other words, so you've got autoimmune hemolytic anemia, right? And so the pattern is, the is prehepatic, right? So isolated hyperbilirubinemia. So and the way that you can tell is that there's the D-bili is low, and I didn't include the LFTs, but the other ones would have been normal. And so again, the direct Coombs is telling you the RBCs are already coated with antibodies. In other words, the question that you're asking is, did hemolysis already happen?
Yeah.
Perfect. All right. So let's go to Mary next. So Mary, what pattern of LFT abnormalities is this? And what condition is most likely? All right, we'll go to Deb. Deb, what do you think?
So there's elevated alkaline phosphatase, and so the ratio of ALT to alkaline phosphatase is less than 2, and so this is a post-hepatic pattern.
Great. What else can you use to help? Okay, so that's good, right? So you said ALK-Phos is really high, ALT is not that high. And if you were to do the R factor, then it's less than 2, so great. So that would be post-hepatic. What else can you look at to argue that this is post-hepatic?
The direct bilirubin is high.
Yeah, exactly. It's mainly direct bilirubin. Great. And if you want to quantify it, it's 80%, much more than 50%. Great. What condition is this? Now we got to put it together, right? So there's 2 parts to lab analysis, right? Like you got to say, what's the pattern, right? But you also have to look at the bigger picture and say, what exactly is going on?
There's leukocytosis, and then the CPD is dilated. Is there any cholelithiasis or?
Yes, there is. Where is the stone? Where is the stone located? And why is the leukocyte high?
The CPD is dilated, so the obstruction site, is it cystic duct or CBD?
Yeah, it's got to be the CBD, because if it's in the cystic duct, your common bile duct should not be dilated. Why is the leukocyte count high? Why is the white count high? It's pretty high. 22,000 is high.
There's a leukemioid reaction due to infection or inflammation.
Very good. Exactly. Yeah. So this, I was trying to show cholangitis. Yeah. That would be the easiest way to explain all of these things. You've got really high alk phos, mild elevation of the AST/ALT, and really high D-bili relative to the total bilirubin. Your white count is really high and you've got a dilated common bile duct. This would be very concerning for ascending cholangitis. So your direct bilirubin would be, yeah, so we talked about this. So the pathophysiology, just to be very clear, so you've got gallstone from the gallbladder that lodges in the common bile duct. So the common bile duct pressure is going to increase for whatever reason, probably because of pressure ischemia. You'll have bacterial translocation, right? Because there's bacteria that's just present in the lumen. So they can infect the wall. And as they infect the wall, that infection can ascend. So that's how you get cholangitis. That's the basic idea of getting cholangitis. So the bacteria, it's really easy then to enter the bloodstream. And so that's why you can get such a profound leukocytosis. So this would be pretty scary, pretty severe, or potentially pretty severe. Questions so far? So we just covered the LFT patterns and did some practice, as well as giving you various different ways of thinking of differentiating between the different kind of patterns. Questions so far before we talk about nausea, vomiting, and then make an analogy?
Alec,
Yeah.
it's me, Tanya. On the slide before, so is that actually heading towards renal splanted where you get the hypertension and the altered mental status because you're basically almost in septic shock?
Yes. Oh yeah, exactly. I think that is why. Yeah. Cool. I think that's why you get, because it's basically, it's basically septic shock. Yeah. You hyperperfuse your brain. So you can get.
It's nice. I never knew why. I always knew that it happens, but it's nice to connect the dots.
Yeah.
Cool. Thanks. Yeah.
I have a question, Alec. Would your PT be elevated in that last scenario if it was like really bad and the white count's not like insanely high? It's not like 70,000, but could your PT be,
I guess though, probably not though. No, probably not. Could it happen? Sure. Absolutely. Yeah. But I don't, because you'd have to say that there's a liver failure. Is there liver failure? I mean, it could, in theory, sure. Any infection, any form of septic shock could, in theory, give you liver failure. So if you showed me a picture where like the PT was elevated, could I see a conceivable mechanism how they could have had liver failure? Absolutely. But could you rule out ascending cholangitis because their liver synthetic function is normal? No. Does that make sense?
Yeah. Thank you.
Yeah. Great question. Fantastic question. All right. Other questions?
Sorry about that. It's a question about septic shock one. The reason why we said septic shock, is it because of increased leukocyte count?
Oh, sorry. You caught me. Technically, septic shock is, so the definition of septic shock is actually that you've given enough fluids and they still don't respond to fluids and you need pressors.
Right.
So we don't actually know that they have septic shock here. So I guess technically what I think Matan and I should have said is to say that shock, in other words, insufficient perfusion of your end organs, which is the organ we care about is your brain, right? If you're trying to describe why someone with sepsis could have like encephalopathy or altered mental status, shock could explain why you have altered mental status. But technically, based on these labs, you do not know if this is septic shock, right? Technically, you'd have to say like severe sepsis.
Correct. Yeah.
I like it. Yeah. Gotta keep me honest. Precision with language. Thank you. No, that was really good. Matan? Yeah, absolutely.
Alec, what's the reason that bilirubin or hyperbilirubinemia causes pruritus?
Oh, interesting. So it's not that bilirubin, my understanding is it's not the bilirubin itself that causes, it's a correlation, right? It's BUN increased. People that have high BUN can get like uremia. It's not because the BUN itself, it just correlates with it. I think the same thing is true with bilirubin. My understanding, the way that it was explained to me is that it's because of the bile salts, right? So bile salts emulsify fat, right? So they help basically dissolve and increase the surface area of fat. So that can get into your skin, into your fat. So my understanding is that the pruritus comes from the bile salts itself, not bilirubin. Yeah. All right. So let's talk about some nausea and vomiting, right? The punchline is going to be that nausea and vomiting for the GI tract and cough for the respiratory tract are both confusing, but at least there is an intuitive way of thinking about it. There's a sort of a systematic way of thinking about it. And before we do that, we're going to talk about the gut tube. Zach, what are the derivatives of the gut tube?
Yeah, so derivatives of the gut tube comes from endoderm. So you're going to have your pancreas, liver, appendix, and stomach.
What else?
And then your intestines. So small intestine, large intestine.
Perfect. Yeah, basically everything from like your esophagus all the way
Downwards,
down.
yeah.
Like,
Sorry, those are the gut buds, right?
exactly. Yeah. The systematic way of thinking about it is like your entire GI tract from your esophagus all the way to the upper part of your anal canal, right? That entire length of bowel esophagus. Plus the 4 buds that attach to the GI tract that bud off of it: pancreas, liver, gallbladder, appendix. Great. And so, Feluke, can obstruction of the gut tube or its buds cause nausea/vomiting, and why?
Yes, it can, since there's going to be pressure.
Yeah, exactly. So there are mechanoreceptors, right, that sense pressure, as you said, in the GI tract wall. This forms the afferent signal to the vomiting center in the brain.
Alec, I have a question.
Please.
Is there a serotonin associated with this? Because I was just doing a URL question about how you give on like a serotonin blocker for anything that causes like irritation.
I think it's actually, so like ondansetron, I think is actually a central mechanism.
Oh, okay.
Yeah, the H3, I'm pretty sure is a central mechanism. I'm pretty sure serotonin is not involved in the afferent signaling. I could be wrong. But I'm pretty sure that's a central mechanism. Because again, the reason why I say that is because ondansetron works for things that aren't just GI related. So like postoperative nausea and vomiting, that's like the most common drug is to give Zofran.
Oh, I see.
All right. Good question. But again, this is why it's confusing. So what I'm trying to do with this nausea vomiting portion is to elucidate one aspect of a very confusing topic. Right? Nausea vomiting is very confusing. Like many things can give you nausea and vomiting. I'm not trying to explain everything that can cause nausea and vomiting. I'm trying to explain the things, like a systematic way of thinking about the GI causes of nausea and vomiting. So to hopefully make it more attractable. So Vi, what effect generally does inflammation have on nerve excitability?
Inflammation, doesn't it increase the excitability?
Yeah, it does. Yeah. So I went really deep down to this rabbit hole, but I can tell you, I can summarize it basically by saying that inflammation generally causes both the nerves and the nerve receptors to be sensitized. So again, that's a huge field of research. I was shocked at how many papers and things, like stretching back decades. But generally, this is true. So if you are interested, some of the more representative findings would be prostaglandins increase mechanoreceptor sensitivity. Inflammation also causes an increase in sensitization of nociceptors. There was also these really interesting studies where they looked at why inflammation can cause nerves themselves to become sensitized. Like nerves generally don't respond that well to touch. They don't respond that much to like touch. However, in inflammation, they do, and there's like interesting mechanisms for why. But the general way for your stage in general, right? I think the best way to think about this is that inflammation causes nerves and nerve receptors to become more sensitive. Leah, in the GI tract, what effect does inflammation seem to have on nerve excitability? How can you use this to explain the symptoms of things like inflammatory bowel disease, like Crohn's or UC?
Okay, so if we're saying that inflammation increases the nerve excitability in the GI tract, then in something like Crohn's, that's a chronic inflammatory state. So you're like chronically having the vagal afferent nerves in the GI tract like constantly stimulated. And so you're going to get like probably nausea and cramping and that sort of thing.
Yeah, nausea, cramping, diarrhea. So inflammation leads to sensitization to distension, right? There's a number of papers on this. If you want to look at the PubMed IDs, this is what they are. So the thought, I didn't really know this, but the thought for why like IBD happens, or one of the thoughts for like why the symptoms of IBD happen, is that you get chronic inflammation. So that causes you to become more sensitive to distension. So remember, distension is the signal for the gut to move things through, right? So that's why you give like bulking agents. That's why fiber, right, makes you have to go to the bathroom. It's because you can't digest, well, it's insoluble fiber, right? You can't digest insoluble fiber and it's bulky. And so it distends your gut, and your gut senses the distension, and it causes contraction of the GI tract and causes the peristalsis. And so one of the very common symptoms of IBD and inflammation of the gut in general is tenesmus, right? The feeling like you have to poop, but you're not able to, like, you still have to poop, but like nothing's coming out. And then another symptom that's really common is diarrhea. And so a really tantalizing explanation for that is to just say inflammation sensitizing the gut to distension, which that is true. That seems to be pretty well established. So inflammation sensitizes the gut to distension, presumably because of increase in mechanoreceptors or increase in sensitivity. And so that would explain both why it feels like you always have to go or that you will go but you still can't get everything out, right? Because you're really sensitive to any sort of pressure, and why you get diarrhea. Because again, even just a little bit is going to cause you to feel like there's a lot there, which is going to cause your bowels to move quickly. Kind of cool. Yeah. This is also, as I went down the rabbit hole, hypothesized to play at least a role in things like irritable bowel syndrome. Right. So irritable bowel syndrome. So it is established that 90% of people with IBS have heightened sensitivity to mechanical distension of the bowel. So one of the most tantalizing explanations for why, and at least it explains it in some, it would explain in some of the cases, is that you get an inflammation or infection or something. So that will sensitize you to distension. And for unclear reasons, some people seem to be more likely to have persistence of that sensitization, even when the inflammation is stopped, which is why they have to run to the bathroom so much, right? It's irritable bowel is like the equivalent of urgency for the urinary system, right? Which again, very similar idea. So if you've got inflammation of the bladder, you will have sensitization of the bladder to mechanical distension, right? So normally you have to distend your bladder a fair amount to feel like you need to pee. If you have inflammation of your bladder, even just a little bit of distension is enough to now make you think that you really have to pee and to set off the micturition reflexes. So again, my goal with this lesson was basically to try to give you general principles for thinking about these very common clinical phenomena and to try to help you to see the connections between them in a way that wasn't just you have to memorize it, which is why you see all these links to articles and PubMed IDs and stuff, because I wanted to make sure that this was reasonably well established. Okay, questions so far?
Alec, can I go back to my point about serotonin? I don't mean to be a know-it-all about this. This is just literally the last question I did before our class started. So I found the URL explanation. Can I just read it out and we can make sense of it then? Like the line.
Yeah.
Yes, one line. Yeah, so conditions that cause BI irritation, example, infection, chemo, distension, result in increased mucosal serotonin release and activation of 5-HT3 receptors on vagal and spinal afferents. And then these then relate their impulses to the medullary vomiting center, inducing emesis. So is there? Yeah, so like I literally just did this question before class started, which is why it was like preying on my mind. So it seems as if there's like mucosal serotonin released. Yeah.
Sure.
And then, yes, that's, yeah. And that's like, so the distension causes mucosal serotonin release, which hits 5-HT3 receptors. I think, yeah. I can copy the explanation.
Yeah, let me see. I don't want to, I don't know. The short,
I don't want to disrupt your flow or anything.
The honest answer is I don't know. It would be cool. I would love for that to be true, but I think I'd have to look into it more.
Yeah, you can look over it later.
Yeah. That's cool. No, I love the connection. So Ghana. So tenesmus. So again, tenesmus is the feeling of incomplete emptying when you're trying to poop. To use the proposed mechanism to explain why, like how the patient feels.
We're talking about how like when you have inflammation and it causes increased stimulation, it can cause tenesmus.
Yeah, exactly. Why would that make sense?
I guess that because if like the bowels or whatnot are moving too much, that you can't properly empty what's the word I'm looking for? You can't like properly get rid of all the poop.
So I don't know that it's so much. So maybe there is some effect of like you can't get rid of all the poop. Oftentimes, though, I think that you don't have to invoke that. Remember that with inflammation, you get sensitization of the nerves, especially to rectal distension. So even if, right, so normally you have to have a fair amount of stool in your rectum to feel like it's distended. If you had inflammation, do you think you would need more distension or less distension to feel the same degree of fullness?
Oh, you need
less distension. Yeah, exactly. So if you had enough inflammation, even if you didn't really have much there, it might feel like there was a lot there. Does that make sense?
Yeah, that makes sense.
So that would explain, because I'd always memorized that inflammation causes tenesmus. You typically see that in something like UC or Crohn's, but you don't have to, right? And then I looked a little bit further and I was like, oh, actually, you typically see it in inflammatory bowel conditions. I was like, oh, so I can memorize that. But really, you don't have to memorize that. It actually makes total sense. Cool.
Yeah.
All right, so Moe, so can inflammation of the gut tube or its buzz cause nausea/vomiting? And why would that make sense? All right, we'll go to Paula. Paula, what do you think?
We're going to use the same theory that we have been using. Since we have inflammation, then we're going to have sensitization of the nerve, and this is going to cause for the person to feel bloated and to feel distension, and then this is going to cause nausea.
Yeah, exactly. Yeah, because you're sensitizing all the nerves. So now a little bit of pressure is going to go a long way. Even though it's a little bit of pressure, your gut's going to think it's a ton of pressure. And so now it's going to think, oh gosh, there's some obstruction. We need to get this out. And you're going to feel nauseous.
Perfect.
Completely logic.
Thank you.
Yeah, that's cool. Nice. So Matan, so what is a good way to think about the GI causes? So let's sum it up. So the GI causes of nausea, vomiting. It's a good sort of general way.
So causes of inflammation.
Yeah.
Sorry.
Inflammation or what else?
Obstruction.
Yeah, obstruction. Yeah. Basically, anything in the gut tube or its four buds that causes obstruction, so increasing pressure, inflammation, in other words, increased sensitivity to, or a toxin, right? You got to throw that in there. It's the GI tract. But yeah, basically obstruction, inflammation, or toxin, which is cool. I remember the reason I came upon this was because I was looking at my daughter was just kept vomiting. She was 4 or 5 at the time. And I was like a typical like doctor parent. I was like, let's figure this out. What's going on? Do I need to take her to the urgent care? So I was looking, I was like, oh wow, this is actually a really good way to think, really great way, some like random paper. It's a really good way to think about nausea vomiting, right? And that was basically what they said, obstruction or inflammation. I had the toxin thing. All right, Joni. So can appendicitis cause nausea and or vomiting?
Yeah, it's the same mechanism. Right?
Yeah, same mechanism, right? Hepatitis. Yeah, Grace, what do you think? Grace, can hepatitis cause nausea and or vomiting?
Yes, also the same mechanism.
Yeah, same mechanism. Again, this is what I'm building towards because it was always really confusing to me. What, gosh, can hepatitis give us nausea vomiting? Can esophagitis give us nausea vomiting? Can pancreatitis give us nausea? I don't know, right? Now it's pretty clear. You can, and you've got a mechanism for why. So, Sujith, if you do not have nausea, can you say this is definitely not? No, unfortunately. It'd be so nice, right? That'd be so nice. If you could just, if there was something that was that sensitive, it was that sensitive, but no. The absence of evidence does not mean the evidence of absence. So unfortunately, no. Sue, so is all nausea vomiting caused by GI tract mechanoreceptors? Can you tie every cause to this mechanism? No, unfortunately. That'd be nice. That'd be super nice, but no, you can't. Yeah. However, I still think it's important to think about because again, a lot of the causes, particularly the causes that you're going to see on your test, and honestly in real life too, are going to be GI related. And when someone comes in with nausea vomiting, the first thing that everyone's going to think about is GI, whether it's true or not, it's GI. So it's a good way to schematize it in your head to know how to approach it. All right, so now we're going to tie this to coughing. So Saba, I'm going to make you an analogy, Saba. So nausea and vomiting is to the GI tract like coughing is to the respiratory tract. Right? So Saba, what's a good way generally to think about coughing and the respiratory causes?
I guess with the same concept of increased sensitization.
Yeah. So if inflammation or increase in pressure causes an increase in nausea and vomiting in the GI tract, what would cause an increase in coughing in the respiratory tract?
I'm sorry, my connection was in and out. Could you please repeat that really quickly? Sorry.
Yeah, absolutely. So we're saying that inflammation or pressure cause an increase in nausea in the GI tract. Would it be fair to say that an increase in inflammation or pressure in the respiratory tract could cause an increase in coughing?
Yes.
Yeah, for basically the same mechanisms. If nausea and vomiting is caused by obstruction or inflammation of the gut tube or its buds, then coughing is basically caused by pressure or inflammation in the respiratory tract, trachea, airways, or alveoli. So let's think about it. This comes up a lot. So Deb, what are the 3 most common causes of chronic cough in a non-smoker? So smoking obviously causes you to cough. You got, I guess, inflammation, maybe a little bit of pressure too, but definitely inflammation. So Deb, what are the 3 most common causes? Do you happen to know?
Postnasal drip.
It's pretty good, actually. GERD is the 3rd. So postnasal drip, asthma, and GERD. Great. This is one of the things that you should know because they're going to, especially for step 2, they're going to give you someone that comes in with a chronic cough that's not a smoker, and then they're going to describe to you basically, do they have GERD symptoms or not? Do they have asthma symptoms or not? Do they have postnasal drip symptoms? It's also a pretty common presentation in primary care clinics. So Zach, so bronchoscopy, right? So this is a bronchoscope, right? You stick a little fiber optic thing into their airways and you're trying to look at the different airways and get stuff from their lungs. So if you touch the side of the trachea or the bronchi with the bronchoscope, if I am snaking this in and I go boom, and I bash the side of or just lightly touch the side of the trachea, what's the patient going to do and why?
Start coughing and gagging because you put pressure.
Exactly.
And so it kind of mimics obstruction.
Yeah, again, it's not really, so it's obstruction in the GI tract. It's not really like,
you said pressure and space.
You have a much lower threshold for, because normally there's supposed to be stuff in the GI tract. So it makes sense that you need a lot of pressure to get to the point.
So it's kind of relative,
Yeah, there's not supposed to be anything in your respiratory tract.
Yeah.
Even just a little bit. Yeah, so they cough like crazy. I can tell you this. Yeah, having done anesthesia, it's, really, really, unless you deeply anesthetize someone, You just brush the side of the airway. They cough like crazy. So GERD, can this cause coughing and why?
Yes, it can cause coughing because you have pressure, you have irritation and inflammation.
Perfect. Yeah. So it's causing inflammation of the airways. Great. So you can sensitize the mechanoreceptors, so you will cough more. Great. All right. So Vi, so asthma, can this cause coughing and why?
Yes, because you have inflammation of the small airways.
Perfect. Yeah, exactly. Yeah. What's interesting is that there was I think it was like a NEGIM paper not too long ago where they looked at like the difference between like inflammatory and non-inflammatory asthma and to see who responded better to steroids. And it's, answer, but inflammatory asthma responds much better to steroids, as you can imagine, presumably for this exact reason, or at least partially this reason. So yeah, you get inflammation of the airways, so you sensitize, presumably you're sensitizing the mechanoreceptors, and so you'll increase your coughing. Great. Leah, so postnasal drip, can this cause coughing and why?
Yeah, a similar reason. You have the postnasal drips going down your throat and it's irritating. And so you're, again, similar sensitization going on, and then you're going to cough.
Yeah. In this case, too, I think you also have the mechanical effect of like you have mucus. There's like stuff there. So presumably that's going to cause coughing too. But yeah, I assume there's some inflammatory component as well. So Agana, what would be the likely etiologic mechanism of a dry cough? Because you see this a lot. And like when I was a medical student, it never made sense to me, like dry cough, wet cough. Why productive cough? Like, why does that matter?
I think it matters because with the productive cough, you have an over secretion of like the glands, which causes like the mucus to stay and you have to cough it up. I feel like a dry cough, there's some kind of irritant, but it doesn't cause like mucus to be built up.
Yeah, exactly. Either because of inflammation or because whatever that is there can't be easily coughed up.
Yeah.
But the more likely thing, usually it's because of just inflammation, right? It's often inflammatory, which again would make sense if you sensitize the mechanoreceptors. That's why even just like a gust of cold air can cause you to have bronchospasm if you're an asthmatic. All right, so I want you guys to update your pathophysiologic chronologies and we will talk about it. So what I'm going to do is, again, so instead of just reading it, I'm going to actually read it and analyze it as if I was going to do it myself. So got a young guy, has a 1-week history of fatigue and nausea with 2 days of yellow skin. So he's got jaundice for 2 days. So a week ago, he started to having fatigue and nausea. So vague symptom, although probably more GI. And now you've got some skin yellowing. So you're thinking already GI, either obstruction or inflammation. His past medical history is unremarkable. So healthy guy, no bad habit. He works in a restaurant. So could be nothing, but exposed to like foodborne pathogens potentially. His temperature is normal, heart rate is normal, blood pressure is normal. So vitals are normal. He's got jaundice. There's something going on with his liver because it's large and it's not tender. And so he's got no signs of basically like cirrhosis. So the labs are really going to be the key then. So already, I don't know, I guess you'd be thinking at this point, maybe something to do with the liver. I guess you'd probably be thinking hepatitis, but you wouldn't necessarily know. Hepatitis would certainly make sense with the restaurant thing because it's fecal oral transmission, so that would make sense. This is where the money is. So he's got about a little less than 50% of his total bilirubin is direct bilirubin, which both are elevated. So that tells you that's something going on in his liver. He's got much higher elevations of his ALT than his alk phos. You could do the R factor, but again, this already is above 5 times the ALT over the alk phos. So already, even without multiplying it by 3.5, you should already, this is very clearly intrahepatic. So he's got no signs of liver failure, either acute or chronic. And this is telling you, so anti-HAV IgM. So this is positive. So this tells you that he's got an acute hepatitis infection. Because again, hepatitis A, we'll talk about this probably next time or one of the future ones, but hepatitis A only gives you acute infections. So if you get IgG, it tells you that you've had hepatitis in the past or you've been vaccinated. So the fact that he's negative means that he was not exposed previously, and this is an acute infection. Because if he had IgG, this would be a protective antibody. The fact that he's got anti-surface antibody tells you that he was exposed to hepatitis B in the past. The fact that he doesn't have an anti-core antibody tells you that he was vaccinated. So he was vaccinated against hepatitis B. And so, because he also has no surface antigen. Had he been exposed to hepatitis in the past, like a live virus, and he was infected, but he cleared it, then both of these would be positive and the surface antigen would be negative. So he's got an acute hepatitis A. So this is my pathophysiologic chronology. I basically just walked you through the first part of this. Again, the nausea vomiting makes sense because you've got inflammation in the liver. So you got sensitization, presumably of the mechanoreceptors. And so Zach, very graciously shared this gem. So he said, the choice of antiemetic therapy depends on the source of the emetogenic stimulus. Conditions that cause GI irritation, so infections, chemotherapy, distension, result in increased mucosal serotonin release and activation of 5-HT3 receptors on vagal and spinal afferent nerves. These then relay their impulses to the medullary vomiting center, inducing emesis. So that's great. That's actually really useful. So this would actually, so it would make sense that the common mechanism here would actually be 5-HT3. So you're sensitizing the mechanoreceptors. And so now the mechanoreceptors are more likely to cause release of, for less distension, you'll have more release of serotonin. So that is why you will have nausea. The acute infection, as we talked about, is why you have IgM. And then because he's had a prior HPV vaccination, he was exposed. The vaccination, the key thing to remember is that the vaccine is surface antigen, but no core antigen. So because of that, you'll make an anti-surface antibody, but because you're not exposed to the anti-core, you're not exposed to the core antigen, you will not make an anti-core antibody. So this is our summary of key concepts. I won't belabor it. We went over it, but we will include that in the notes. So questions, concerns, thoughts?
This is a random question, but is nausea is it lessened at all in diabetic patients who have like diabetic gastroparesis or anything like that, or is it altered?
I don't think so. That would be interesting. If you told me that there was a case study of someone with diabetes who, like, I don't know, had knocked out the afferents from their GI tract, and you could blow tons of air into their GI tract and they'd never get nauseous and distend it like crazy. Yeah, I have no reason to disbelieve that, but I don't know that's like a thing.
Thanks. I'm just curious.
Yeah, good question. Other questions? Saba says that was super helpful. Thank you. Oh, great. What was helpful specifically?
Just the way that we like described everything, I really appreciate like having a systematic approach to think through things because I don't know, tackling things without a clear strategy in mind I don't think that's anyone's first choice approach. But yeah, I just really can't emphasize how much I appreciate like giving us like a structured approach to these kinds of questions for like tests and.
Awesome. Thank you. Yeah, I feel the exact same way. Yeah, I felt like I learned a lot of this stuff in very like haphazard ways, and I had to piece together with like gum and twine, like a general approach. But yeah, it's interesting. It's much more pleasant. Like it's just much more fun to practice medicine or to do questions or things when you have a systematic sort of way of thinking about it. Cool. Awesome. Thank you guys so much. Again, we are continuing on with GI. I think there may be a point in which we may branch off a little bit and do a little bit of question interpretation, or I've also noticed there's two sort of steps with Anki. So one of the steps, and just like learning material in general, the first step that is already a difficult hurdle to clear is if you get a fact, can you make sense of it and make a good card? So if you get this random fact, I don't know, inflammatory bowel conditions, oftentimes you get tenesmus, right? Can you make sense of that? Can you do something where you can make sense of that? That in and of itself is pretty hard. Most people don't do that. They'll just memorize that. And so you're left without a systematic benefit to knowing that fact. I've noticed that a lot of people struggle with that. I've also noticed, though, that a lot of people really struggle with the idea of mastering a broad topic. So I'm probably going to have something in the course, either in the course or lessons or both, where we talk about like where we actually practice this, because I think it's really important. I will say for people whose scores do not improve, I would say the number one reason is they're just not really learning things very well, or they're not really retaining it very well. That's almost always, especially if your scores are stuck at lower amounts, like less than 220, 210 for either step, but especially for step one, it's pretty common to see that being a major problem. So thank you guys very much. I will see you guys next week. Last time we talked about making key concepts automatic. This is all in the service of, on your test, the more that you can automatically know what every sentence means, the better you will do. I can virtually guarantee that. You read a sentence and you just know what it means, your test is going to go much more smoothly. I don't think that's a controversial thing to say. The hard thing is to figure out, how do we do that? Last time we talked about making key concepts automatic. This idea that you want to be able to see someone that's hypotensive and tachycardic and immediately be thinking about the baroreceptor reflex. That's the first step. The second step, though, is to actually be able to put it together in an actual vignette and to drill these vignettes. What I've done here is I've created vignettes where we're going to A, drill those automatic key concepts that they just become something that you reflexively see when you're doing questions. But B, I'm going to give you cards and that you can then turn into vignettes that you can drill these concepts and continue to reinforce the connections. We're going to start with Hadra. The way that this is going to work, actually, all of you guys are going to read this vignette, and I'm going to call on Hadra because I want her to tell me what the pathophysiologic chronology is. But for all of these, I want you all to do it, and I will choose one of you to go over the pathophysiologic chronology. Everyone read this. You don't have to read it out loud, but I want you to tell me what's the pathophysiologic chronology. Walk through the pathophysiologic chronology, and I want you to specifically tell me what's the mechanism for developing type 2 diabetes and why is he orthostatic?
The mechanism for type 2 diabetes is mellitus is that there is insulin resistance, and that insulin resistance results in increased insulin production and increased amylin production. And that amylin production, whenever there is increased production of proteins in our body, there's always going to be increased production of misfolded proteins in our body. And some of those misfolded proteins can be ubiquitinated, and others are not degraded by ubiquitination. And those proteins aggregate, and one of those proteins aggregating and through hydrophobic interactions is amyloid. When we have type 2 diabetes mellitus, we have a lot of insulin production because the cells are essentially resistant to proteins, and we have a lot of production of misfolded proteins, and we have a lot of production of amyloid, and that amyloid aggregates because of hydrophobic interaction into beta-pleated sheets, and then that actually deposits in the pancreas, and that results in dysfunction of the pancreas. Over time, the pancreatic beta cells become dysfunctional, and there is even more decreased production of insulin, which really results in a relative insulin deficiency.
That was really good. I am really impressed. I don't even think I need to teach that what I was planning on teaching. That was really good. Great. So why is he orthostatic? Walk me through the pathophysiological chronology. How do you connect all this now?
It's just that obviously diabetes mellitus equals hyperglycemia. The blood has a lot of blood glucose inside it, and because of that blood glucose, there is non-enzymatic glycosylation of the arteries, and because of that, I think there is basically less blood flow. The normal response of when a person gets up is that initially when a person gets up, there is pooling of blood in their veins. And because of that, there is a decreased preload in the heart, because of which there is decreased stroke volume. When the stroke volume decreases, there is decreased cardiac output. And when the cardiac output decreases, there is decreased MAP. When the MAP decreases, there is a decreased stretch on the baroreceptor reflex. And there's a decreased stretch on the baroreceptor.
Okay, so that's good. You're walking through the normal healthy mechanism. What I'm asking is why
that's
is it...
normal. But in diabetes mellitus, there's basically the nerves are basically weak because the blood can go to the nerves and it's not providing the nutrients. The nerves are not functioning at their best. When we get lightheadedness, and we have an alpha activation and we have vasoconstriction, that is basically being prevented, and the blood is not able to go to the person's brain, and that's why they're lightheaded.
Okay, how did that feel?
Yeah, that felt okay.
Yeah, that's not bad. It felt a little meandering at the end. In a test, it would be a little hard because I feel like the risk that you run with going into so much detail on the normal mechanism is that it's going to take too much time. Granted, this is a artificial scenario, but in an actual test, that would probably be a little, like going over the normal baroreceptor reflex is probably too much. But otherwise, that was actually quite good. What I'm going to show you is, this is the level at which, in an actual timed test, this is probably the level at which I would think about it. You don't have to go into details about how do you get diabetes. I asked you to go through the details of why you get diabetes. Someone was asking, what do you do in an actual test? What should you actually do in a test scenario? You can't go through, thinking about amylin. Every time diabetes, you can't be thinking of amylin production because of insulin resistance. That's just too much. You just say diabetes. In a test setting, this is about the level at which I would think about it. There's some sort of diabetic neuropathy of the autonomic nervous system. You get baroreceptor reflex dysfunction, and that's why you're getting hypotensive and orthostatic. That's it. However, when you're not doing this in a test, in a non-test scenario, I would want you to go through as much detail as possible. And the reason is because the more detail you can give, the more that this will become natural in your test, and the more that you'll be able to review it. Let's talk about some of this. This is the mechanism of type 2 diabetes, which Hadra just explained. There's insulin resistance that leads to overproduction of insulin. That insulin overproduction also, amylin is released along with insulin, which leads ultimately to amyloid production. The amyloid leads to beta islet cell dysfunction, and now you have a decrease in insulin supply to go along with increase in demand. And that is diabetes. Technically, it just means diabetes mellitus technically just means you have high blood sugar. This I took directly from the lecture Endocrinology, the diabetes mellitus and thyroid lecture. Briefly, to walk through the mechanism of getting amyloid, you have a protein, some proteins, there's a non-degradable part. And if there's misfolding, you'll get ubiquitination of it. And if you're step 1, they love ubiquitin, love the proteasome. It seems to always be the answer when that's one of the answer choices. You can degrade the degradable part, but the non-degradable part, the hydrophobic part, you can't degrade. When you're making more and more proteins, in the case of having insulin resistance and having increase in insulin, you will then accumulate these non-degradable parts. But the non-degradable parts will accumulate, and eventually what happens is that they polymerize. They now join together to form the superstructure of the beta-pleated sheet, which we call amyloid. Great. What's the significance of the fact that he had 20 years of diabetes and that is poorly controlled? Why did I say that in the vignette? And why do they say that in other vignettes? Pooja, what do you think?
You wanted to draw attention to the fact that poorly controlled diabetes can lead to the renal. Does the guy have renal failure? I forgot.
He had renal failure. Yeah, why did I say he had renal failure? Why was that important? Why would you have to include that? Or why would I include that in the vignette? Play directly into the orthostasis, right? It didn't necessarily play directly into the vignette, but it was still important. It's because the point is that a lot of these late manifestations happen similarly, concomitantly, right? Kidney disease oftentimes happens with like retinopathy, but if you're going to get peripheral neuropathy, it's also reasonable to think that you are at risk of having autonomic neuropathy. I was building towards this idea that he had autonomic neuropathy. Tingling in hands and feet may seem like a distractor, but really what it's telling you is just the overall state of his disease. If someone says, oh, this is someone who's got insulin-dependent diabetes, insulin-dependent type 2 diabetes, it just means it's really bad diabetes. Someone comes in with diabetes and they've got kidney failure, it just means that they have really bad diabetes and they are at risk of having these other complications. Great. We talked about this last time, but I don't want to spend too much time talking about this, but the normal baroreceptor reflex was what Hadra was going through. If I was going to make a tattoo, it would say MAP is cardiac output times TPR equals heart rate times stroke volume times CPR. And then preload, afterload, and contractility. Sometimes you can think about rhythm. And this is the mechanism. But hopefully you guys have, every single time that you've been standing up, you have been thinking about the baroreceptor reflex so that you can make this an automatic key concept. Because I guarantee if you're not drilling this into your head now, on the day of your task, it's not going to come to mind naturally. You're going to be time pressured, you're going to be stressed. This is the last thing you're going to be thinking of. The time to practice this is when you're not in a timed setting. When you're exercising, when you get up, when you stand up from a seated position, when you get up from bed, whatever it is. Right? But you want to learn how to make this automatic. Because the more that you can make knowing the right answer or knowing what every sentence means automatic on your test, the happier you will be with your score. I can guarantee that. We talked about heart rate last time. I don't want to spend too much time talking about this, but the reason that M1 causes an increase in heart rate is because of the phase 4 depolarization. Danielle, what's the equations for cerebral perfusion?
Cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure.
Great. And how generally can you think about when I say perfusion pressure? What's a good way of thinking about that?
Resistance? Is that like in the...
Oh, no, like in general. If I think of blank perfusion pressure, what's the generic equation for perfusion pressure? That's a bad question. Basically, what's the pressure of the system that you're coming from? Right. In this case, it's the arterial system. Minus the pressure of the system you're going to, right? In this case, it's the brain inside. In general, because a lot of people just memorize this. I'm saying you don't have to memorize this. You can actually make sense of it. The perfusion pressure on your brain is what's the pressure of the blood going to your brain minus the pressure inside your brain. Pretty much it. The other famous perfusion pressure equation, which we'll talk about eventually, is coronary perfusion pressure, which is usually written as aortic diastolic blood pressure minus left ventricular end diastolic pressure. Because your coronary is filled during diastole, usually, at least the left-sided ones. and they're going to the heart, where ultimately, right, the blood is going to end up in the left ventricle. You're looking at the diastolic blood pressure, but it's coming from the aorta. It's ending up in the heart. The perfusion pressure is just pressure is coming from minus pressure is going to Hadra. Tell me, why is he lightheaded? Using the cerebral perfusion pressure equation, why does he get lightheaded when he stands up?
He gets headed because the MAP decreases and the intracranial pressure is high. Basically, the cerebral perfusion pressure decreases.
Yeah, I don't even know that I would say that ICP is high. The ICP is probably normal.
Okay.
But the point is that the ICP is unchanged. If this decreases relative to this, then yeah, your cerebral perfusion pressure is going to go down. Yeah, cool. Yeah, great. When someone presents with lightheadedness or syncope when they're standing, what's the general mechanism behind lightheadedness? And could this be a stroke? Pooja, can you tell us, what's the general mechanism behind lightheadedness and or syncope?
Oh boy.
Remember you were saying before, you were like, yeah, someone comes in unconscious. Yeah, I don't know what that means. What, you're supposed to know what that means? Yeah, this is pretty much. Yeah, the general unconsciousness is a little different from syncope, which I'll explain. But yeah, it should be automatic. I've bolded all the questions that I want you guys to make into cards. We'll give you the cards.
The whole chronology.
Well, so yeah, there's going to be two kinds of cards. There's going to be the ones that I bolded. This is an automatic key concept. This is a concept that I want you to make automatic. When you see someone that's lightheaded, you want to think hypotension. In a very general sense, if someone's intermittently lightheaded or if they're syncopal, maybe not 100% of the time, but I'd say 90 to 95% of the time, particularly in questions, particularly for syncope, if it's truly pre-syncope or syncope, virtually 100% of the time it's going to be. I know there's going to be haters out there who are going to say, actually, technically, you can be syncopal from, yes, technically it's true. But that's really uncommon. That's hotter balloonists. Yeah, but in general, you should think hypotension when someone's lightheaded. I bolded this because I want you to make this an automatic key concept. In other words, I want you to be thinking about this when you see syncope. Oh, I know they're hypotensive. It should just come to your mind. That's what I want. Pooja, does that make sense?
Yes.
Perfect. I'm just spelling it out for you. This is what I wish that people told me. Pooja, can you tell me, could this be a stroke? If someone presents with lightheadedness, what's the likelihood that this is a stroke if they're lightheaded?
I think it could be.
No, almost never a stroke. That, I would argue, is probably a cognitive error. And I think if I had to reconstruct it, I think that the way that it happens is that people think of lightheadedness as a brain thing. Then your system one just goes, headedness, brain pathology. Oh, what's a brain pathology? Oh, yeah, stroke. Strokes are brain pathology.
Here's a case where sometimes you do get a patient that comes in and says, like, scenario will say, the patient comes in with the lightheadedness and the syncope, blah, blah. But then the vignette's talking about the symptoms of a stroke.
I've yet to see a vignette like that. Please bring that next time.
I'm not saying that I've seen it. What, again, I struggle with is when I see something like this and I associate it with the hypertension, am I going to lock myself in? That's what I kind of get scared of.
Oh, great. Yeah, exactly. This is why you have a system too, right? I'm not saying that if you say hypertension for syncope, you're going to be right 100% of the time. There's maybe a couple percent or 5% of the time where it's not going to be that. In other words, what was the trick of using your system two? What did we call that last time? Trust but verify. In other words, say, oh yeah, totally. I think that they are most likely hypertensive, but then verify. Do they have other symptoms of hypertension? When you look at the blood pressure, is it low? You still have to check it. I'm not saying that your test is just going to be like you're not thinking at all and everything is going to be automatic. No, absolutely not.
Yeah, approaching questions with system one, and I'm doubting my questions with system one as well. Like system two is like non-existent for me.
Exactly. What I'm trying to do with this is I want to strengthen your system one. I want to strengthen your system one. Your system one is giving you the right answer more frequently. However, we also need to strengthen your system too, that it can take that answer and actually evaluate it and say, oh, does this make sense or not? But I think the problem is that a lot of you guys, your thinking is more to this. Oh, lightheaded. Oh, yeah, lightheaded. Oh, it's brain. Oh, brain problem. What's a brain problem? Oh, yeah, I think of stroke. No, that will lead you down the wrong path virtually 100% of the time. I've bolded this because I want to make this an automatic concept. When you see syncope or pre-syncope, you should be thinking hypertension because in virtually 100% of, I'd say 95% of the time, just read fair, you should be thinking this will guide you in the right way. Mighty said in her text to me, she said, I think it's good to think of stroke as focal neurological deficit, which is totally true. Trust but verify. What's the classic presentation of stroke? Well, the classic presentation of stroke is a focal, sudden neurologic deficit. You suddenly have trouble speaking, you can't move your leg or something like that. That's the classic presentation. Great. Next, let us, Danielle, I want you to walk us through maybe just the overall big picture in terms of the pathophysiologic chronology.
Basically, this elderly man was born healthy, probably some poor life choices, a bit poor diet, maybe decreased exercise, led him to develop diabetes type 2. Well, led him to have insulin resistance, an increased insulin resistance, which caused an increased production of insulin to compensate for the resistance. And then this caused an increase in amylin. Do you want me to go through everything?
But I think that's big picture. That's actually, yeah, this is a delicate thing. I guess I would say when you're doing it on your own, I would want you to go through everything. For the interest of time, to make sure that we can cover enough vignettes, to reread it a little bit.
Since we already discussed the whole process of how type 2 diabetes occurs, I'll just go over that, skip that. Basically, his long-standing type 2 diabetes led him to have these kind of end-stage factors such as renal failure and the autonomic dysfunction. And the autonomic dysfunction caused him to have a baroreceptor reflex dysfunction, so he's not able to the job, like he stands up.
Keep cutting out. I think what you're saying is that he can't augment his cardiac output, which means his MAP doesn't increase. And because his MAP doesn't increase, his cerebral perfusion pressure falls. I think that's what you're getting at. What I've included here, the bolded questions, are the key concepts you want to make automatic. You see someone that's pre-syncopal, you should think hypertension. You should not think stroke. Pre-syncope or syncope, virtually, 100% of the cases, at least for vignettes, and even in the real world, is almost always because of hypertension. Vasovagal syncope, hypertension. Cardiac syncope, any of the causes, aortic stenosis, hypertension. Non-sustained VTAC, hypertension. All of them, they're all hypertension. In the test, this is about the level of detail. In a question, that would be one card, or the bolded things, we will include that. The other kinds of cards that I'm going to include is this one. The front of the card would be this vignette, and the back of the card would be this. And when you're reviewing it, should you do the summary or should you use the detailed one? Which do you think is better? Doralis, what do you think? If I'm reviewing this and I'm not in a time setting, which do you think I should go through?
Detailed.
Absolutely. Yeah. And a fair question is, Alec, isn't this just a god-awful waste of time? Why would I do that? Why would I? Seriously.
Muscle memory for your brain.
Yeah, exactly. Because all of this stuff, I guarantee, certainly for step 1, but even for most of this for step 2, are things that are going to be on your test. Yeah, it's going to take you a little bit longer, for sure. But then you look at all the things that you're reviewing. It's crazy. There's all this stuff. And the other benefit is that, yeah, you're essentially creating muscle memory that the next time you see someone who has some form of autonomic dysfunction and they've got diabetes and kidney failure, and you're like, oh, I totally makes sense. Because maybe next time it's not going to be that they have, maybe it's not that they're going to have autonomic problems of a sympathetic system in terms of blood pressure, but maybe it's that they're going to have diarrhea. There's just no clear reason why. And you're like, oh, you've got tingling hands and feet and kidney failure. It stands to reason that they might have autonomic dysfunction as well. Maybe they've just got a problem with their sympathetic system into their GI tract. Their parasympathetic system's overactive and they're getting diarrhea because of that. You want to train yourself to be able to make these connections on the spot. And if you wait until your test, until you try to make them, you'll never make them. It's not going to happen because it just becomes that much harder on the day of your test to do this in a timed setting when you're stressed. Just not going to happen. That was great. I'm going to ask all of you guys to read this quietly to yourself. And then I'm going to have Doralis walk us through what the pathophysiologic chronology of this one is. This one's pretty tough. Doralis.
Born healthy male, I guess he's probably had some unhealthy lifestyle changes or habits, that with the smoking. And now at elderly age actually, I don't know where to go to here. I know what
It's hard. This one's hard.
has, but I don't know how to get to from this.
Yeah, I know. Okay, does someone else want to give it a shot? This is one of the harder ones. But again, this is totally fair game for your test. Maite, do you want to give it a shot?
61-year-old man used to be emergency department. Working in neck pain, there can be a lot of things, but he had lightheadedness. 1 month history of upper mid-thoracic back pain. I think of something maybe aortic perisection.
Okay, so stop. Let me point something out to you guys. Your system 1 is unaware of time. Let me repeat this. In other words, your system 1 doesn't really know what happened first, what happened second, what happened third. It's just completely oblivious to time. You have to, if you're going to think about the actual chronology, you actually have to arrange the vignette in chronological order. I want you to actually arrange this in chronological order. What happened first and then what happened second, just in terms of the elements of the vignette. You don't have to tell me why it happened, but just which sense.
This was a healthy man, and then he started smoking, which is a risk factor to develop 20 years ago. That's a long time. And that inquisitive of a lot of things, but he has a CT that demonstrates that he has a mass on the pancreas. Maybe he starts smoking, this increases risk to develop pancreatic cancer, and pancreatic cancer develops his, how do I say this, hypercoagulability. Also, he
Again,
kills
the
smoke.
chronology.
It's a 60-year-old man who starts smoking, developed pancreatic cancer, leading to develop trouble. He has a DVT, and then he developed PE, and the PE. Worsening pain is because of the DVT, and then the DVT progressed to a PE, pulmonary embolism, that gave him the lightheadedness.
Perfect. That was fantastic. That was great. Do you see how different it is, though, for those of you that maybe weren't able to make all those connections? My guess is as you were going, it was hard to tell because you were going down the wrong path of, I don't think I was being very clear in what I wanted. But the key is that you oftentimes what you'll see, this is exactly how they're going to give it to you in the vignette, because this is the chief complaint. He comes in, they might not even give it to you like this. They might even say a 67-year-old guy comes in with a 2-day history of lightheadedness. And that's it, because that's the chief complaint. And then they might tell you for a week he's had worsening left leg pain. And then they'll say he's had a month of worsening upper thoracic pain, because this is HPI business now. And then they're going to tell you about their smoking history, this 20-pack year history, way down at the bottom, because that's where the social history goes. What I see a lot of you guys do with your pathophysiologic chronologies is they're not actual chronologies. You're just going sentence by sentence, which is essentially what you were doing, I think. Right? That's not what I want.
I want to ask you a question while I practice, while I do my job.
When you do your test, do this. You should also arrange them chronologically in your mind, because it's hard. It's harder, yeah. Because if you don't arrange it in your mind, your system one's not going to do it, right? You're not naturally going to do this. No matter how many times you do questions, you're not naturally going to make those connections. I would argue that when I present it like this, I guess a lot of you guys were like, oh my God, I have zero idea what's going on. But if I were to present it like this in the actual chronology in which it happened, I didn't even tell you that he had pancreatic cancer. I didn't tell you any of the background of any of these things, right? I just now have just arranged them in order of the actual timing of them. It became much more clear what was going on when you arrange it in that order.
Yeah, I think as I finished, because when I read the vignette, I start taking things out and I finish before the dialogue, but I do it really quick. That's maybe why I think I might not do it, but yeah, because it's a second read, I don't know how to explain it.
Pooja, what are your thoughts? If you saw it this way versus if you saw it this way, which is easier for you, Pooja? What do you think?
I think the bottom, it's a little bit more clear why one 20 pack year smoking history is the reason that he's got the pancreatic mass, is the reason he's got the weight loss, is the reason he's got the upper back pain. I would think that this would be the easier one.
Totally. Yeah. Are you naturally going to do this though?
I'm trying.
Yeah. I guess my point is that your system one will not do this.
Right.
Just reading a vignette, this will not become immediately obvious to you. Instead, when I read a vignette, whenever I see like days, weeks, I actually take an extra second and I actually think this happened first. I would read this and I would say, okay, so he's got leg pain and then lightheadedness. Oh, actually before that, he's got back pain, then leg pain, then lightheadedness. And they're like, oh, actually no, it's smoking, then smoking, back pain and mass, leg pain and lightheadedness. I actually think, and as I'm going, I'm trying to put those pieces together.
Well, if you think about that, then they should put the social history as the first thing in the vignette. So
Well, not necessarily, because the social history isn't always one of the key things. The reason why the H&P is laid out the way that it is because then you know what to expect, what to listen to in every step. You could argue maybe that you could put it in the HPI, but they will not always do that for you. They will not, both clinically and on your test. But I want you guys to see that it's much easier to see the connections if you actually arrange it in chronological order, which is why I keep telling you guys, you have to make actual chronologies. It's not sentence by sentence in terms of, that's not what a pathophysiologic chronology is. You have to read it sentence by sentence. But what you're trying to build in your head is this happened first, this happened second, this happened third, this happened fourth. And I would argue that this is the exact same process that you should be doing clinically. Because if you just think about it in the order that the patient tells it to you, it is much, much harder for you to make sense of it than if you're saying, take me back from the beginning. When is the first time that you were well? Actually think, okay, try and make it in chronological order. So this would be the summary. As you're going through the test, this is about the detail that I would want you to go through it in a time time setting. Smoking leads to cancer, pancreatic cancer, I mean, a lot of things. But in this case, it was the major risk factor for getting pancreatic cancer. And then smoking and pancreatic cancer are two, right? So what you guys didn't talk about was the fact that it's not just pancreatic cancer. He was smoking too. That's 2 out of 3 of your cause triad. That leads to DVT. Low amount leads to cerebral hyperperfusion. Of your cause triads, what are the 3 elements in your cause triad? Hypercoagulability, venous stasis, and endothelial damage. Danielle, what does Virchow's triad predispose you to, and how many are necessary in order to be predisposed?
Yeah, so it'll predispose you to getting embolisms and PEs and things that you need 2 of the factors.
Yeah, it's basically venous clots, CVT. Yeah, I typically need 2 out of the 3. Great. And Danielle, which elements of Virchow's triad does this patient have?
Yes, our patient has the pancreatic cancer causing the hypercoagulability, and then the long history of smoking, which is going to cause the endothelial damage.
Perfect. Smoking is endothelial damage. Pancreatic cancer is hypercoagulability. Great. Duralis, what is it? Generally, what does it mean when they say that there's a provoked or an unprovoked DVT? What is that referring to?
I'm not sure, but I'm assuming it has to do with if you're causing it due to something that you're doing, lifestyle changes, problems, or versus no.
Yeah, provoked basically means that there's a very clear precipitant, very obvious. Unprovoked is where it's not immediately clear what is causing it. And Hadra, which would be more concerning, the provoked or the unprovoked, and why?
I think the unprovoked is more concerning because in provoked you have a clear precipitant that you can take care of. For example, in our case, smoking, we could tell the patient to quit smoking. For unprovoked, I think we're more concerned as to now we have to dig in about the
Yeah, what would you be concerned about?
Yeah.
Yeah, usually unprovoked are much more concerning. Oftentimes the thing that you worry about is genetics or some sort of undiscovered factor. For this guy, they didn't necessarily know that he had cancer. Presumably he didn't know he had cancer when he presented to the emergency department. It's a double whammy. It's, oh, by the way, you have DVT-PE. Oh, and by the way, you have pancreatic cancer. But the pancreatic cancer was that unclear precipitant. It was the one that you didn't know about. But that's what you really worry about. Actually happened to one of the professors at Stanford. He just developed a DVT. And it turns out, right, it was an unprovoked DVT. He was playing tennis. And it turns out that he has factor V Leiden. Wow. This stuff is real. That's crazy. But yeah, that was unprovoked. Great. Now I want to talk about resistors. Let's talk about resistors in series versus in parallel. So Luis, you can think about blood vessels, resistors in series or parallel. This is series. It's where one resistor is after the other, after another. I have no choice. I've got to go. If I want to go from this point to this point, I've got to go through all the resistors. If it's parallel, I've got a choice, basically. Technically, I'm not choosing, but there are multiple paths through the different resistors that I can take. These are resistors in parallel. Louise, can you tell us what's the total resistance equal to if there are resistors that are in series?
Would it be the sum of the 4 resistance?
Yeah, it is. Yeah, total resistance is you just add them up. It's the easiest one. If I remove a resistor in series, what's the effect, Luis, on the total resistance? Going to increase it or decrease it?
It will decrease it.
Yeah, great. Right? Because it's just a story. Take this out, it's going to decrease it. Great. Pooja? For resistors in parallel, what's the total resistance?
1 over R1, 1 plus R2
Equals what?
equals, I don't know.
Does it equal the total resistance? Yeah. What is it equal to? Yeah, everyone remembers this side of the equation. No one remembers this side of the equation. It's actually 1 over R total. And I've made this mistake multiple times. I used to think that it was R total equals 1 over R1 equals, right? That's why I asked you, because I've definitely made that mistake before. But no, it's actually 1 over R total equals 1 over R1 plus 1 over R2 plus 1 over R3. Because that's important, because Pooja, what is the effect of removing a resistor in parallel? What effect? Does it increase the total resistance or does it decrease the total resistance?
In parallel, I think it increases.
Yeah, it increases it. Great. Let's prove it. Let's prove it to ourselves. So let's just make the math easy. We've got 3 resistors. They all have the same resistance, and that resistance is 2. I'm going to use units just to make it really easy. 1 over R total. This is for parallel. This is in parallel. It's going to be 1/2 plus 1/2, 1 plus 1/2. If we rearrange the terms, we'll find that R total, right, is 2/3. Now, let's say that we remove one of the resistors. Now, we've taken out R3, let's say. Now, it's just 2 resistors. 1 over R total equals 1/2 plus 1/2. But what do you know? The total resistance is now, it's one of those weird things, because I haven't really thought about reciprocals for a really long time. But do the math, prove to yourself that removing a resistor in parallel will increase the total resistance. Great. In other words, if I have a PE, what's it going to do to my pulmonary resistance? Danielle, would I consider my left and right pulmonary arteries to be resistors in series or in parallel?
Resistors and parallel.
Great. And if I had a pulmonary embolism to my right pulmonary artery, Danielle, what would be the effect on my total pulmonary arterial resistance if I were to think of them as resistors? This is a key concept. I've bolded it.
Yeah, if we're thinking about our pulmonary arteries in parallel, then if you were to remove or block our right pulmonary artery, then you'd be removing one of those resistors in parallel. Then your total resistance would increase.
Perfect. Yeah, exactly. Excellent. Excellent. It's duralis. How could a PE lead to hypertension? That's a key concept.
Since the PE that it's in parallel and you're taking away one of the resistance on one side, it's causing an increase in total resistance though. Then that increase in total resistance is going to lead to a decrease in forward flow. That's going to cause you to have less blood pumping forward, including to your left side of your heart, meaning less stroke volume, less cardiac output.
Skipping a step, why is there less volume? Think of your tattoo. You're going to make a tattoo.
Okay. So anything that's in front, or I guess after the pulmonary embolism, is going to have a decrease in preload. If you have an increase in preload, it's going to cause an increase in volume to your left. Decrease in volume to your left atrium, which causes a decrease in volume to your left ventricle, and that's how you get the decrease in stroke volume.
Sorry, this might be a technicality, but really, I guess the way that I would think about it, and I think the way that they to test this would be, I would say there's a decrease in volume to the left atrium, decrease in volume to the left ventricle. That's great. I would say that means that there's a decrease in preload. Because I think what you were saying, maybe I misunderstood, was that a decrease in preload leads to a decrease in volume. That's not usually how it's described physiologically. Usually you think of it from the context of the left ventricle itself. There's a decrease in left ventricular volume, which means that there's a decrease.
Okay, that's true. Left ventricular and diastolic volume.
Correct. Yeah, exactly. Yeah, that's what you think of as preload. Not that preload leads to a decrease in your left ventricular inside. But yeah, decrease in stroke volume.
Decrease in stroke volume leads to a decrease in cardiac output, which leads to a decrease in your MAP.
Great.
Decrease in your mean arterial pressure means less blood in your arterial system, which means less blood to your brain.
Remember, the key is that you want to use these concepts that we just talked about. If you don't use them now, you're not going to use them on your test. It's not going to be automatic on your test.
I don't know what's the term for that. Maybe I wasn't here.
Perfusion pressure. Oh, you might not have been here. Yeah, cerebral perfusion pressure.
Oh, so is that the cerebral? The cerebral perfusion pressure equals
MAP minus ICP.
because your MAP is decreased.
Yeah, your cerebral perfusion pressure is decreased. Yeah, exactly.
Okay.
In other words, yeah, larger PEs are more likely to give you hemodynamic effects to drop your MAP. And it's that decrease in MAP, which is ultimately decreasing your cerebral perfusion pressure. And that's where you're lightheaded. Great. Now, I want you to read this exact same vignette. Now that you've learned those key concepts, now that we've drilled those key concepts, right? Now I want you to read the vignette and I want you to tell me, because my hope is that now you're able to make the connections automatically much more. In order to further that, I want you to make this into a card and actually think, why does he get a TVT? Why is he lightheaded? Why is he tachycardic? Padra, can you tell us? Can you give us the high level? Don't go into really excruciating detail, but just the high level summary. And then we can save the excruciating detail for when you guys go over this on your own.
Yeah, the pathophysiology chronology will be such that this 67-year-old has been smoking for the last 20 years, and that's a risk factor for pancreatic cancer. And both of those are risk factors. They kind of make the Virchow's triad. There is endothelial damage and there is hypercoagulability, which results in DVT. And the DVT from there dislodges an embolus, which causes PE. And that PE actually increases resistance to blood flow. And there is decreased cardiac output, which decreases the MAP and which decreases the cerebral perfusion pressure. And when the cerebral perfusion pressure decreases, and the decrease in MAP also results in activation of the sympathetic outflow because of the baroreceptor reflex.
Perfect. Honestly, that's okay. Like that level of detail. Because again, I want to train you in two ways. I want to show you when you're going through this in a timed setting, you have to know which details to cut and which to not. Right? What are the big picture elements that you need to still have a complete story, a reasonably complete story, versus what are you going to do when it's on your own and you want to go over these details because these are details that could certainly be tested in other. In a test, this is it. I'd say smoking pancreatic cancer leads to DVT to PE, low MAP, perfusion. Done. In a test, this is about as much detail as I would give. But outside of a test, this is the level of detail that I would try to do. I would even get down to the point of saying, yeah, you get a PE. The PE leads to you're removing the resistor in parallel, because that's a really important concept, thinking of resistors in parallel versus in series. And then, yeah, go through all of it. Cool? I think we might even have time for one more. Luis, I'm going to have all of you guys read this, but I'm going to have Luis go over the pathophysiological chronology. Luis, would you like to give us the pathophysiological chronology?
A 36-year-old woman who was born healthy. They don't specify for how long she has been smoking or using the oral contraceptives, but let's say that she was born healthy. When she gets to a reproductive age and starts having sexual activity, she starts taking the oral contraceptives, and she probably starts smoking as well. She probably develops a DVT, or
she smokes some CPs. Then she takes a flight.
Yeah, that sentence in the chronologic sequence. She was a 36-year-old woman. She was born healthy. She smokes, uses OCP, and then she takes a long flight from South Korea to LA. From sitting down for quite a long time, she develops DVTs. During the flight, she gets to LA, and all of a sudden she starts complaining. She probably develops DVTs, and then those clots.
I'm going to stop you there. That was not bad. What I want to point out is that this is probably how a lot of vignettes feel to a lot of you guys. You're reading it, and honestly, you probably don't even give it as much effort as Luis just gave. You probably just, oh, I don't know, took your venous extension. Oh, that was clear. And you just you choose an answer. That's usually about the level that I think most people understand most vignettes. And there are two choices that you have when you see a vignette like this. The first is to just say, oh, look at the answer, read the educational objective, and say, oh yeah, I get it. Oh yeah, whatever. I'll get it next time. The second thing, which is what I want you guys to do, is to actually go through and make sense of the pathophysiological chronology. I actually walk you through step by step when you have the answer in front of you. Because what you'll find, and the reason why I'm showing you, I'm very intentionally showing you the vignette at the beginning and at the end of each of these, is because I want to show you in the beginning, you're often not sure what's going on. But then afterwards, you're like, how could someone not see this? And Luis, this is what I want to prove to you. I want to prove to you that you're gonna be like, oh, I totally got this. Makes total sense. And if you make a card on this, and if you repeat this card using detailed pathophysiological chronology every single time, when you see a question like this, and I guarantee you're going to see a question like this in your test, it may not be this exact same scenario, but it'll be very similar. You'll know it. You'll know it, because our goal is to make sure that you know automatically what every sentence is trying to tell you automatically in your test. This is the summary. Basically, she's, our previous guy, smoking and pancreatic cancer, was 2 out of 3 because right. This lady's got 3 out of 3, smoking, endothelial damage, and she's got hypercoagulability, and because of the OCPs, and she's got venous stasis. She's got a whomping DVT, which becomes a large PE, that leads to right-sided heart failure. And the fact that it's right-sided heart failure is critical, because that's why she doesn't have crackles in her lungs, and that's leading to hypotension, and ultimately, again, cerebral hyperperfusion. Cool. Let's talk about heart failure. Pooja, what does heart failure mean? It's kind of this vague term.
Well, the heart's not able to pump blood adequately, or
adequately for what? Adequate for what?
For the body's needs.
I know. It's the one time that the medical student answer is correct. Something really vague, but yeah, it's true. So basically, it's if you can't meet the body's blood demand, right? Or, you need excessive volume or pressure to do it adequately. The classic heart failure patient is they've got JVD up to their earlobe, and they've got inspiratory crackles and all this stuff. That they have adequate flow to they may have adequate flow to their body, but they need so much volume to do it adequately. That's still considered heart failure. Let's talk about, Pooja, you had a question?
Yes, I did. About the previous vignette, when we were talking about the Virchow's triad, when we're doing this on our own, should I think about what specifically in the blood is causing the hypercoagulability and is allowing? I don't know.
If it was a time setting, what do you think?
Oh, no.
No, I probably wouldn't do it. Yeah. But if it was not outside of a test, maybe not every time, But I would say, yeah, you should think about what exactly is the mechanism which OCPs cause hyperbilirubinemia? Sometimes I don't know. I don't really understand why cancer. I guess they say that there's mucin or something and it causes a tissue factor, I don't know, substitute or blah, blah, blah. But yeah. But in theory, yeah, you should try to walk through exactly what, at least once. Yeah, because the more that you walk through it, the more automatic you're going to make it on your test. That's the goal. As long as you remember that, I think it will make it a lot easier for you to think, oh, should I do this or not? Luis, do you have a question?
Yes, I was going to ask something related to the clinical vignette that I was reading. Usually, the DVTs will be the cause for pulmonary. The DVTs, they will go into the pulmonary artery causing a PE. But then I got a little confused because when I saw the distension of the jugular veins, I didn't think of...
Let's talk about this. Let me ask you a question. So what are the signs of right heart failure? It's like I planned you there to ask that question. What are the signs of right heart failure?
Increased, jugular distension because of the overload in the superior vena cava, and from there up, basically a jugular vein distension. What else?
This is good. I'm glad that, basically almost everything that you think of as signs of heart failure are basically signs of right heart failure. Ascites, hepatomegaly, splenomegaly, jugular venous distension, lower extremity edema. All of those things are essentially right heart failures. We should make that into, that should be something that you should know. You should absolutely know. That is a key concept that I want you to make automatic. Puja, or I think we already did Puja, Duralis. What's the mechanism of getting lower extremity edema in right heart failure?
Because for whatever reason, your heart is not able to either push that fluid forward, it's causing a backflow of the fluid. There's an increase in pressure due to the backflow.
Yeah, it depends on the cause. In this case, there's an increase in afterload for the right heart, but that's not always going to be true.
But when you say increase in afterload, it could be calling it the right heart, and you would just have to say as opposed to just...
Yes, exactly. You have to specify afterload for the right heart.
Anyways, there's a accumulation of fluid that is causing your heart to fail in the sense of not letting it push forward. That's going to cause that to move from the ventricle, all that fluid from the ventricle up to the atrium, and then go into your venous system. That tends to cause the JVD, the jugular venous distension.
Lower extremity edema. We're focusing on one symptom or one sign.
In the end of the day, all that backflow is just going to cause an increase in your venous system to the point that your capillaries have a high hydrostatic pressure and cause that filtration.
Yeah, exactly. Yeah. You get venous congestion, particularly in the dependent areas. Yeah, you have capillary. It's in the capillaries, not really the venous system. Your capillaries are the thinnest part. So that's where if there's going to be fluid leak, it's going to be across the capillaries. There's more fluid leakage in the interstitium. That's what gives you peritoneal edema. Great. Hadra, on a test, or just in general, how do you differentiate between left and right heart failure? Because they always say, the most common cause of right heart failure is left heart failure. How do you differentiate between that for combined left and right heart failure versus just having isolated right heart failure?
In isolated right-hand heart failure, patient will present with edema, hepatomegaly, ascites, JVP raised, but clear lungs. The lungs will be clear. But in left heart failure, because of the backup of blood, the lungs will not be, and yes, we'll have pulmonary edema, and pulmonary capillary wedge pressure will be raised.
Yeah, exactly. Usually what they'll say is they'll have inspiratory crackles. If they have a pulmonary artery cancer, which is pretty rare, but if they did, right? But both actual and real life, very few people get pulmonary artery catheters, but also in vignettes, they don't really have wedge pressure or pulmonary artery catheters that often. Almost always it's going to be the lung. I can't tell you how many times I'll see a question, it's about heart failure, and you'll say, oh yeah, you'll see pitting edema or something. And they have no idea why they're like, oh, clear lungs. Oh, it's because there's no pneumonia or something that's completely unrelated. Oh, no. Anytime that they give you signs of heart failure, you want to listen to the lungs, both in real life and in your vignette, especially in the vignettes, because they're not going to come out and just tell you, oh, it's just right heart failure. They have to give you a sign that it's just right heart failure, to give you a sign. And really, they're really restricted in the signs they can give you, because almost every sign of heart failure is really right-sided heart failure. If there's signs of right-sided heart failure without pulmonary edema, you should think isolated heart failure. Sometimes, literally, that is the only clue that they're going to give you, and that's how you're supposed to answer the question. Now, I want to go back to Luis. Luis, it's always hard to be put on the spot. It's always hard to do these questions. But I want you to tell me, now that we've reviewed these key concepts, right? Now I want you to tell me, what's the pathophysiologic chronology here?
36-year-old woman is born healthy. She
starts smoking and using oral contraceptives. She takes a very long flight from South Korea to LA, where she develops DVTs in her lower extremities. Those DVTs will go to the pulmonary artery as a pulmonary embolism that will decrease the preload.
Preload to where?
Yeah, that will decrease the preload, causing a decrease in the stroke volume, causing a decrease in the cardiac output, causing a decrease in MAP, and causing decreased cerebral hypoperfusion.
That's awesome. It's really interesting. I heard you say you're PE causing, there's a lot of hesitation, decrease in preload. But then, did you guys hear? It was like decrease in stroke volume, decrease in cardiac output, decrease in MAP, cerebral hyperfusion. It was just like that part was automatic. Did you feel that, Luis?
Yeah, basically what I was practicing from the sessions from Tuesday about just making sense of something and then just try it to be automatic. Once you get to the point where you understand the clinical vignette, and then just from there on, just try to connect what variable affects the other variables that's why just like you said, I hesitated a little bit, but from that PE for all the way to the decrease in the preload, the rest was basically automatic. A decrease in the stroke volume, decrease in the cardiac output, and then decrease in MAP, and then decrease cerebral brain.
But I think one of the things that you said that struck me was you said you've been drilling it since Tuesday, and now it's just become automatic. My thought when I hear that is that the same thing is going to be true for this vignette. Yeah, the first time that you saw this, it was pretty slow. The second time you saw this, part of it was slow, but other parts of it were faster. I guarantee that if you were to continue to just repeat this vignette, right, in your cards, and just the repetition, the practice, and make the connections every single time, that the next time you see this or a similar vignette, because there'll be similar vignettes, it will just be much faster. Just the end of this vignette was. What are your thoughts, please?
Yes, I couldn't agree more. I think that if you just the rest of the Yankee cards, if you see the same card over and over, it doesn't matter if you don't study the card for a month or a month and a half. Whenever the card appears, then the basic or the idea of the card just comes up automatically because you've been seeing it for quite a few months now. It doesn't matter if you go a couple of weeks without seeing that same concept. Once one of the either the back or the front part of the card, you automatically can recall the clinical vignette related to the card you were seeing. Yeah, I think that repetition is the most effective way of just remembering stuff. Because if you read it one time, if they change the clinical vignette and if you haven't practiced the key concepts of that card over and over, you might hesitate a little bit. I just did. I knew that it had to do something with the DVTs and the PE, but then I hesitated which was the parameter that was affected, in this case the preload. But I hesitated because I wasn't sure at the beginning, but then the rest of it just came out automatically. And I think it's thanks to the session we had 3 days ago.
Yeah, but it's because the other thing is, yeah, like you can see as you're doing the pathophysiological chronology of the question, you can see where the rough spots are. It's just telling you, yeah, maybe that's the area that we want to focus on. That's the area, because you guys were asking, where are you supposed to focus on? Focus on the parts that are slowest. I know it's more pleasurable to do the ones that are faster, but I think Pooja was mentioning before, it's really pleasurable. It's hard, but you get this sense of satisfaction when you can see a vignette and you know exactly what every single sentence means. It just feels good. It just feels awesome. And I can tell you, it feels doubly awesome when that question is on your test, your actual exam. You're like, oh yeah, I know what every single sentence means. I know why they're trying to tell it, why they're including it, why there's a print negative. You just get it. You feel like such a boss. Yeah. But it comes from, you want to continue to make these automatic.
I have a question. She had a PE, and because of that, it's causing the lightheadedness. But I'm assuming, I guess PEs can have different severities, because I guess this wasn't that severe. She's having no hyperventilation or like.
Oh, just because they don't say something doesn't mean it's not there. That's it.
But is that something like it might not have
hyperventilate? Oh yeah, if they told you her respiratory rate, it would be high.
Okay, so it's like a for sure thing. Like she actually is having trouble breathing and all that. It's just not like, oh, I feel kind of lightheaded. I might have a DVT. It's not anything like that.
In other words, the lack of a symptom doesn't necessarily mean that it's not there. This is one of my pet peeves about rule in and rule out is that oftentimes you guys will say, oh, this is ruled out because if it was this, then I would expect all of these symptoms. That's not necessarily true. First of all, clinically, that's not necessarily true. The diseases don't present in the classic way every time. There is such a thing as sensitivity and specificity of clinical signs and symptoms. And that doesn't even work in real life, but it certainly doesn't work in tests either. In this case, oh, the fact that she's not hyperventilating means that it can't be a large PE. They didn't tell you that her respiratory was normal. You don't have a pertinent negative. Does that make sense?
Yeah, that makes complete sense. Yeah, that's good to know that it can't just rule it out because it's not there. But I guess for future knowledge, PEs generally it's not because oh, she had small.
Large PEs are the ones that are hemodynamically significant.
Okay, little ones probably won't even cause lightheadedness.
Small PEs would not cause lightheadedness unless you were very fragile.
Where you had some prior lung disease or something.
Yeah, if you had right heart problems to begin with, yeah, a small PE might be the one. But yeah, just think about it. A small PE is likely only to remove a very small resistor in your pulmonary arterial system. Removing a small resistor is not going to change your pulmonary resistance that much. A large PE is going to remove a large resistor from your pulmonary circulation. If you knocked out the right pulmonary artery, that's a huge resistor. That's going to cause a dramatic change in your pulmonary arterial resistance. That would be enough of a drop in preload to cause hypertension. But notice, I have made that concept automatic. This is a meta view, but you see how quickly that came to mind? It's because every single time I see these changes either of increase in resistors or decrease in resistors, if I see a patent ductus arteriosus, or I see an AV fistula or something like that, I'm thinking about it in terms of resistors in parallel and series, so I can see it as a side note. But yes, to your point, large PEs are the ones that will cause hemodynamic changes. Small PEs generally are just going to give you chest pain and hypoxemia. Thank you guys. This was great. I want you to come up with your own automatic key concepts, or you can even you can take the ones that we have here or in the previous presentation. But I want you to post them as a comment on this video, knowing the right answer automatically. I want you to post them here so that we can all see how each other's doing and also to give feedback. Awesome.
Now that you can see how family medicine patterns repeat across step 2, the next step is learning how to practice them the right way. In my UWorld Complete guide, I'll walk you through the exact phase-by-phase system that turns what you already understand into 260+ performance in step 2. Click here to watch how to virtually guarantee your next score jump.